counter that push, and it just receives the push. So this is a hyperinflation on the left, pushing them to the right, and they hold on to that state with all of their inhalations and exhalations, and it holds the foot pronated. The pelvis turned and tipped like this. The lumbar spine turned with the pelvis, and the rib cage turns back. Low compressed right shoulder, grounded right side. So imagine up at the neck, the entire column of the body is shifted over to the right and oriented to the right. That's different than turned. Oriented didn't really do anything, but just kind of got oriented. So now the head has to respond to that orientation by actually rotating left and coming out of this with a left lateral flexion. So you see this blue curve in this drawing shows a left side bending, but it's also a left rotation as it side bends. So that's what the neck's doing. The transverse processes on the right push up, as Mike taught you earlier, and push right up into the occiput on the right. And the right occiput has to respond to that. It can't just get pushed, it has to respond to that, and it goes into a turn. It goes into a turn, and it goes into a forward glide. Because it's getting bumped up, it has to do something, and so it just turns out of that, and it gets bumped forward. So the forward head with a turning head, with a high right side of the neck, gives them this left lateral flexion that we're showing you here. We call it left mid-cervical lateral flexion. We'll show you how to assess what we really want when someone's stuck in the right side like this. We want in our measurements to see right mid-cervical lateral flexion. Because left mid-cervical lateral flexion tells us we're stuck in the right, we want right mid-cervical lateral flexion telling us that the body has access to the left. So when the neck doesn't go to the right, that tells us, oh, you are missing one half of your movement profile. Your neck just told on your entire body. And so as we go to move the neck, know that we're not orthopedically studying the neck, but we're studying the neck. It's a window to the entire body pattern, and it shows up at the neck because the neck is one of those crossroads where we have to compensate out of body patterns if we get stuck in them. And that's a top-down, that's a bottom-up comment and also a top-down comment. Okay? There's going to be a degree of scoliotic curve to this person because when their pelvis turns and their rib cage counters back, their spine has to ride that curve and actually become that curve. So it's a rotational right thoracic curve as their body comes back, but their neck is very oriented to the right. They're very compromised, as Mike said earlier, getting air in the right chest. So their right scalenes, their right SCM, their right upper trap is going to carry a lot of undue tension. And it's really the body trying to put air in a lung that can't get air in because they're so stuck over to the right. But truly, if you keep backing it up through this mid-region, it's the diaphragm being overly shifted and overly rotated to the right. And then 17 to 28,000 breaths a day, with that driving diaphragm influence, it literally just turns you onto the right lateral foot, also known as the right molars. So it's a constant respiratory phenomena in the middle, driving the foot and ankle phenomena below and driving the neck and the cranial and the occlusal phenomena above. We showed you this and we spent a lot of time on this, but you have to know why this now top-down view is spinning this occiput, temporal bones, and mandible to the left. It's that constant upward push right up under this arrow because that neck is constantly turning back and coming up on the right side. It's just bumping into that occiput, and that occiput just glides out of it. It's a beautiful compensation that we can even do that until we do it so much and can't get out of it. Now it's not beautiful anymore. It gets ugly. But as you recall, we're rotating left here. We're bringing the sphenoid back to the right here, and that brings the maxilla. You'll remember, typically, the left maxilla is internally rotated. That discludes this left side, and this externally rotated right side, as this maxilla rotates toward this mandible, that's also rotating towards it. That's a collision point. And that's a place where the right teeth can be well sensed, normally, for people who are stuck on the right side. Not always. It doesn't always do that. We're actually kind of glad when it does do that. And then we help guide them out of that, and we're on our way to solving the pattern and the problem. sometimes the occlusion is very confusing, or it's doing multiple things that don't correlate well with the body. That's where we really need your help to give the brain a sense of being able to feel and sense one side without undue interference, and then be able to feel and sense the other side so we can get the body to shift into each hemisphere without a similar interruption. These again, we're just further describing what I think we've done a pretty good job. Mike, any comment you would have about things that you'd like them to appreciate when they see this drawing?
No, because we're going to do some phenotypical views in just
Okay,
a minute.
beautiful. The thing we want you to appreciate here is that this maxilla is in a rightward migration, and we are going to increase right molar contact because of that combined action, including, remember Mike showing you the IR and the ER of the palate? If you have an internally rotated palate over here and an externally rotated palate over here, coupled with a palate that's rotating toward the mandible and a mandible that's coming at the palate, that's just a contact point. That's an oversensed point because the body's over here, and all of this had to respond to the body being over here as opposed to it just being an occlusal issue. But your centric relation changes with the occiput as those temporal bones are brought around. It has to, because your temporal mandibular, your temporal part of your temporal mandibular joint is moving with the occiput. And then the sphenoid is countering back to keep all these bones in your skull. That nice side bend occurrence or strain that occurs allows that maxilla to come back, and you're able to still occlude well, if you will, but the strain on the bottom teeth and the top teeth and the IR and the ER of the maxilla can change what you sense and feel here. And I want to emphasize, this is not bad unless you get too much of it and can't manage it, but we love that your brain senses this. Now this sense pulls your body into this pattern. Now we need you guys, because we can't get you out of this pattern because your brain keeps overriding our work therapeutically to try to restore this, and your occlusion says, no, I'm going to make sure this sense gives them that body. And so now we need each other. Now we really desperately need each other. Again, we took this all the way up and we saw this internal rotation here and the more external rotation here. ER, yep, IR here, ER here, ER here. Anything else you want to say, Mike, about maxilla, premaxilla? We've said all of this. I think you guys have seen this. This is all just review material I want you to appreciate, but I want you to realize that body below it did all of this.
Please forgive me, because I'm not understanding the ER where it says the PM. Is that premolar? Is that what
Premaxilla?
Maxilla, yeah.
I
So
don't know if I missed something when I
Okay.
it, or I'm just.
Mike's got the, go ahead, Mike, with that.
So let's first look at the maxilla. So the maxilla on this side, this wall, is steeper than this wall. Can you see that?
Yes.
So it's harder to see in this particular model, premaxilla. But typically what you'll see up in the premaxillary region where the incisors are, is that where you have IR in the maxilla, you'll tend to see ER in the premaxilla. And where you have ER in this maxilla, you'll see IR here. Teeth tipping in, teeth tipping out.
Okay, now I see it. Thank
Got
you.
it?
Okay, got it.
Thank you for that clarification.
But what about the body?
Mike, I'm going to give you
So
this.
this part is kind of easy and fun. About time, right? So there's two things I want to cover in this next section, and I'm going to try to cover them relatively quickly so that we have good lab time. So I'm going to talk about observations, just casual observations, and then some testing, and then why people clench in the daytime. And then we're going to dive right into lab, okay? So if you had x-ray vision and you were looking at somebody from the back and you looked at their left shoulder blade and their right shoulder blade, this muscle is called levator scapula. What you're seeing here is the cervical column rotating to the left. So this would be someone in right stance. So if I did that in front of you, facing you, I'm this. My cervical column is rotating. It's everything we've been talking about today. And if I turned around, it would be that. So I just want you to appreciate what we call a type 1 scapula, or an internally rotated scapula. The bottom angle is tipping away from the rib cage. And everything here is represented in opposite fashion on this side. It results in hyper-twisting of the left levator scapula and hypo-twisting of the right levator scapula. Levator scapulas love to be twisted, and they operate from a neutral twisted position. Neither of these is neutral. Levator scapula symptoms tend to show up deep neck, more on the left side, at tenderness palpation at the transverse process tips. Trap pain is usually here, and it's usually on the right. That doesn't mean it never shows up opposite. Plenty show up opposite. But I want you to visualize this and kind of remember this, and let's apply it to these guys. So what you're seeing now, and I'm not asking you to have folks come into your clinic and strip for their dental work. What I'm asking you to do is kind of put a shirt on this guy. Put a shirt on that lady. They're going to walk in looking like I'm looking now. You're going to say, yeah, you know, I've had this problem, and it's been kind of a yada yada, and that shoulder's down. You're just seeing it. You're just noticing it. Just be aware of it. So in both of these instances, what I do want you to notice is that pronated rib cage. That pronated rib cage. That type 1 scapula. That type 1 scapula. What these people are asking for you to do for them, or for James and me to do, is could you please put an air valve over here someplace and deflate me, and put another air valve here and pump me up. Because I need to learn to put air in this side, and I need to learn to get air out of this side. Get air out of this side and put air in this side. This was a kid, I used him in another PowerPoint, and he had right shoulder pain from impingement. He was on the Little League World Series baseball when my hometown won it, and he was the pitcher. Shoulder pain, low back pain. 14 years old, scheduled for surgery on both. 14. But all he really needed was an air valve and an air valve. He's fine. She is a tennis player with right big toe pain. We didn't touch her big toe. We just worked on some breathing, and she's fine. So, but just think about the shoulder blades underneath. So that's thing one. Thing two, look at the shoulder blades underneath. She's hanging out right now telling you my right rib cage is in internal rotation. My left rib cage is in external rotation. I'm inhaling into this chest as I tell you my story. My right shoulder then appears lower than my left. Do you see that? I like to hang out with my left leg crossed over my right while I'm telling you my story. Because when I cross my left leg over my right, it tends to put me in my right hemisphere so that I'm more comfortable while I'm telling you my story. How is it more comfortable? I don't know, it just is. We know why. Because that way she can pull air into her left chest more readily. So she's just comfy. It's not a big deal. She's just comfy there. If we lay somebody down, we might notice the very same thing, only now they're laying down, but I want you to notice two things on this image. Image thing number one is the obvious internally rotated right rib cage, externally rotated left rib cage, but what do you see here? This is what Alice was saying about lay them down, and sometimes you see things that aren't so obvious when they're sitting up. This is in Seattle. This is in Houston. They got the same rib cages in Seattle as they do in Houston. This is Houston.
Guys, that air is shoving them over. They're literally getting shoved over by the excess air that their body pattern puts excessively into one side and is compromised on the other side.
Isn't this could be a reason that people will intuitively sleep on one side?
Absolutely. Her sternum is oriented here. Her rib cage at around T8 is turning back to the left and up. T8 and up, which is where people turn at the diaphragm level, which is at T8. So what you're seeing is just, this is casual evidence. Here's your best evidence right there. Right there. This is you chatting with your patient. Yes, Neela?
So can you go back to the purple?
Purple shirt?
Yeah. So where are her teeth hitting?
You tell me, boss.
I was thinking they're going to hit on the right.
Ding, 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 ding. That's right. Tell us what she's won, Johnny. That's it. You nailed it. You nailed it. And don't you love that? So now if we did, I get the biggest kick out of if you happen to watch somebody walking down the hall who only hits teeth on the right, you might see an absent right upper extremity swing. They'll have a dead right arm. Why isn't that right arm rotating? Why should it? They never go into their left hemisphere to rotate their thorax to the right. Why would the arm go behind them? Doesn't need to. I just swag. This is me. I'm Mr. Right Thoracic Abduction. Boom. Boom. That's it. That's it. Rothbard talked about what feet look like, and he said abnormal foot pronation is synonymous with a pronated left face. These feet belong to this face. Why do you suppose he has a hallux valgus? Because when you push off on a foot that's rolling in, you're pushing off on the medial edge of the great toe, which drives the toe that way. Make sense? So if your patient shows up in flip-flops, take a peek. It's right there. You didn't have to even tell them to undress. Just take a peek. If you see them with hallux valgus bilaterally or on one foot or the other, something's up. You don't even know what's up. Just know something's up. And then start contemplating that. I just love this slide, James. With the Rothbard reference in there. It's just awesome. It's like everything in one slide. Scapular positioning, there it is. Huh. Now what do you suppose she did in picture 2? She breathed. But what James is going to tell you, is she exhaled. She got the air out of one side. So I said Allred Fonder in 1974 put a Gelb splint in somebody's mouth to straighten their scoliotic curve. So she's bending over in Atlanta, Georgia. This stuff must be in Atlanta too. So she's bending over in Atlanta, Georgia. So we know this young lady is going to wind up with something in her mouth to help her control that scoliotic curve. And it will work. But she's got to work with it. She's got to have a breathing program that accompanies whatever goes in her mouth. Well, how much will that breathing program help me, Mike? I don't know. Breathe out and bend over. And let me take a second picture of you. Holy mackerel. She's now bought in. So she'll be compliant with the program. That's like 10 seconds. Who's this person? I've got a whole case on her. No, that's in Atlanta. That's in Atlanta. That's a scapular dyskinesia softball thrower. ALF and splint. It's the only way we could get her to have long-lasting results. It's a beautiful before-after I could show you. You'd die. You'd just die. I did show her in that where we were eating out in that restaurant. I flashed her up there. She's the girl with the crazy scap. Remember her? That's her. While observation is a great thing, and we love it, we have to use objective tools. Enjoy the view. but validate on the table or in the chair or in the chair while they're chatting with you, giving you their history. Validate and understand that we need objective data. Objective data. So one thing that you can look at is this thing called humeral glenoid internal rotation, or HGIR. The glenoid is the socket of the shoulder blade, and the humerus is the ball. If you block the shoulder and internally rotate the arm, you're going to see a limitation in internal rotation if the scapulas are in the position of the drawing. Remember the drawing. So if the scapulas are here, you're going to see a difference in rotation. If they have two type 1 scapulas, you'll see bilateral limitations in rotation, and there's a name for that. So there's a name for everything. What we're showing you is normally abnormal, because that's the mothership. All we're doing is expanding your mothership. So this is a typical finding in most of the patients we see. Block the shoulder, rotate the arm, 90 degrees. Block the shoulder on the right, rotate the arm, 40-ish, 45, 20. So that's what you would typically see, and we're going to do this.
So you're just needing resistance.
Yep, I'll run into a block. Patient's laying on the table. I block here, I rotate. That's the end. It's a bony end feel. There was a physical therapist named Gray who started doing all that study on glenohumeral internal rotation deficit. He called it GIRD, G-I-R-D. And he did this study on this thing, and he said, you know, if you have a limitation here, it's because this, he was talking about athletes. He said these athletes have scarring in the shoulder that's limiting their ability to rotate. Now what James and James are going to say is hogwash. He also went on to say if you stretch that shoulder doing something called a sleeper stretch, for 6 weeks you can gain as much as 10 degrees of internal rotation range of motion. But what I would submit to you is in 6 seconds you can gain 90 degrees if you just have a patient breathe out or disclude them. Hear what I'm saying? If you take them out of their accustomed habitual bite, you can go from 45 to 90 degrees. The power of occlusion is huge. Some of you have experienced that on your own bodies. So the first test we're going to be doing is this one in just a few minutes in lab. And then I've got some videos of the next tests. So I've got the following slides illuminate for the examiner the following: available mobility towards cervical extension, available columnar rotation, meaning the cervical column, available columnar lateral flexion. Patients who are lateralized onto one hemisphere of movement without the ability to efficiently shift into the other will demonstrate limitations on these movements. Oh, I got to hit play. Sorry, I got it.
Okay, so this is an assessment of cervical lordosis, or the ability to lordose, or the ability to extend. My hands are placed on the transverse processes of the cervical spine, and what I'm actually doing is lifting the middle of the cervical column to see how well it can make a curve like that. So that's how this test works. I'm just lifting on the middle of the neck. Okay, so this is an assessment.
Now here we go. This is on a human.
Okay, this is assessment of cervical lordosis. All I'm doing is placing my fingers on the transverse process of the mid-cervical spine, and I'm just barely going to lift as though I'm lifting my hands toward the ceiling. And what I'm looking for is how much the middle of her neck gives toward the ceiling. Got
Guzman
it.
and Anderson, how well would you rate Tammy's ability to lordose? Mild, moderate, not too great? What do you got?
She has the ability to lordose moderately, but some of it's coming from her OA.
You saw that head start to extend back, and you also did you see the chest lift as well? Jay,
That tells me that up near the top of the cervical spine, more of that action was occurring.
Yep, at the OA.
And down near the lower segments of the cervical spine, there was less segmental movement. You could see that as her cage started to come forward.
Now with them,
But she did extend.
she did extend. So we would have all kind of been of the mindset that it moved. It wasn't great, but it did move. So let's play it again. I want you to watch what James said about her head pitching back a lot, and watch what James said about her chest kind of lifting as we lifted the neck. So there was a little bit of coupled movement between the actual neck and the body. So I'm going to play again and watch.
Okay, this is assessment of cervical lordosis. All I'm doing is placing my fingers on the transverse process of the mid-cervical spine, and I'm just barely going to lift as though I'm lifting my hands toward the ceiling. And what I'm looking for is how much the middle of her neck gives toward the ceiling.
So it's not
Got it.
horrible in either. We say way worse sometimes. Sometimes we see no movement in the neck and all head. Or sometimes it's like trying to watch this table segmentally move. And that ain't happening. It's like lifting a brick. So she wasn't a brick, but she wasn't a slinky either. Boy, a perfect neck would be a slinky. Here's the slinky, you know, it's slinky. Remember that? So you hold the slinky like this and lift the middle. And this end doesn't really move much. This end doesn't move much. It's just butter. That's what you're looking for, butter. All right, so let's do the next one.
This before you move on?
Yeah.
It's really a test to see how well the rib cage supinates or fully exhales, closes, and draws back relative to the neck. You see a neck coming forward. I see a rib cage that couldn't quite go back as much as I needed to stay on the molars and to stay on the heels and to fire the hamstrings and the abs to support the diaphragm. It's just a different way of looking at it. But I didn't know that cage goes back, and I didn't know if that head goes back so that jaw can go forward, and you're telling me right there that it can't quite because the head got pulled with the neck.
If a neck has a normal curve, it's 30 degrees. You have a 30-degree cervical lordosis, a 30-degree thoracic kyphosis, a 30-degree lumbar lordosis, and a 30-degree tailbone. So it's 30.
To airway when you have a 30-degree lordosis.
You are in my head, girlfriend, because that's what I was about to say. If it's 30, 30, 30, and 30, your airway is open. If you start straightening your neck, now we start getting into something. Because, and this is what we're testing, what straightened the neck? Well, longus colli, scalenes, sternocleidomastoid, all of these anterior muscles, but especially longus colli, begin to reverse the normal cervical curve and make the neck too straight. Why in the world are they doing that? It's paradoxical. Yes, they're trying to help this human breathe. They're struggling to lift the rib cage. The more military I am, the straighter my neck. If somebody ever gives you a chin tuck exercise to do, run. Because all they're doing is having you do more of that. This straight neck, you lay this neck on the table, it seems like, my gosh, it seems like if this neck is really straight, it would lordose. Because it has somewhere to go. If it's straight, it's compressed.
So
When
if
it-
you guys start looking at CBCTs and you're seeing these small airways, don't just look at the airway and call it small. Look at the lordotic curve of that neck. Check out the human being, because you start pulling that jaw forward or expanding, and the neck's straight. What do you think it's gonna do when you pull the jaw forward and the neck is already straight? It's gonna make it worse and smaller. It's not gonna help the patient.
It's why it can lead to more
It's gonna cause the
TMD.
patient want to go more forward because now they're constricted from breathing. So it's paradoxical. Does that make sense? So we see airway as an orthopedic problem. It's not.
Once it's not. Once you put a curve back in that neck, and I don't care how you do it, you can use a chicken's foot and a rattle, it doesn't matter to me, but as long as you get a curve back in that neck,
Laborious splits.
then what you'll wind up with is a neck that has the ability to lordose. Which brings me back to what James said about this rib cage supination. If somebody lays on this table who has a pretty straight neck, We could just guide the rib cage down and see their neck curve, like in 2 seconds, and then test them and they'll have a mobile neck. Whoa, what's all that about? Or release that tongue. Release that tongue. Whoa, all of a sudden they got a curve in their neck. Kind of cool.
So in our heads, we're thinking orthopedic, release the tongue. What if it drops back and you close the airway? Remember, we think that.
Yeah, that's
But
true.
what if you release the tongue, it gives the curvature back and opens the airway? Because you've seen it both ways. People have said, when I release the tongue, all of a sudden I can breathe everywhere.
That tongue
But
knew
why
where to
did
go.
that tongue drop back and close the airway? I mean, don't y'all think like, you hear all these principles, you're like, it's not matching up to what I've learned. You know, so this is the missing link right here. It's the posture stuff.
Let's look at the next one. Okay, so here's the next test that you're going to be playing with is called cervical axial rotation. You'll see the skeleton in 2 directions, then you'll see the human. So here's the skeleton.
What you're looking at is the base of the skull and the entire cervical column being held in my right hand. When assessing cervical axial rotation, you're assessing rotation of the entire column in one direction or the other. In this example, this is left cervical axial rotation.
Normal cervical axial rotation range of motion is 30 degrees. What's with all the 30s? It's 30 degrees. I'm going to punch this, and we're going to go to the next video, which is just a quick version of the same thing going to the right.
In this example, this is right cervical axial rotation.
So I got a question for you.
Again, measuring the entire column, not individual segments of the vertebra.
So I'm going to assume a position called right hemispheric occupation. I'm going to rotate to talk to the back row. What's up, guys? I'm going to finish that rotation here at my neck. So I am left laterally flexed and left cervical axially rotated. Now, you're going to lay me down on the table. Which rib cage is probably going to be higher if you looked at me laying on the table? My left. Which direction would you think that I would have less cervical axial rotation when you tested me? Would I have less to the left or less to the right? You can't say both. Did you just say both? She went left, right? So I've already rotated left. So I'm probably not going to have much more going to the left. Does that make sense? Neutral on me if you laid me on the table. Okay, I'm going to lay on the table. I've got a bigger left chest. I'm laying on the table. Neutral isn't here. Neutral would be right about here, following my sternum. Make sense? This is my neutral position relative to my rib cage, shoulder girdle in this example. Isn't that weird? So when I'm laying on the table with my head straight, it's not straight. I just think it's straight. And a lot of times your patient will lay on the table kind of like this or kind of like that. And you're like, wow. And then when I see that, I'll take their head and put it way over here someplace. I'll say, put your head back in the middle. And they put it right back in that crooked spot. I'm like, so that's the middle for you, huh? And they're like, yeah. And I go, how about that? What does that feel like? I put it in the middle. And they go, oh, no, that's not the middle, Mike. I don't know what you're talking about. And I go, yeah. Click with my phone. And Tammy goes, why the hell do you have some dude's head on your phone? I'm like, I don't know. Why do I have some dude's feet on the phone? Or why do I have some dude's teeth on the phone? You know, I have the stupidest pictures on my phone. So, hey, he does too. And I know he does too. So I'm not the only weirdo in the room. All right, so I'm going to go to the next. Do what? See? Tongues. All right, so this is an example of cervical axial on Tammy.
Okay, so this would be cervical axial rotation on a live human. So I'm taking her neck until I feel it stop, which is about, in this case, 20 degrees.
Now,
30 degrees is normal. Stop.
all right, so I want you to know my left hand isn't doing anything. It's just on her head. My right hand is doing the work. I'm rotating her head to the left. My left hand is just coming along for the ride. My right hand is the working hand. If I rotated her head to the right, my left hand would be the working hand. You can do this test with 2 hands. I found it to be nothing but all thumbs when I try. It's just easier for me to grab a handful of neck, turn it. What I'll do sometimes is I'll show the patient when I rotate that head to the left and it stops, they go, I can keep going. And I say, yeah, I know you can. If I take that head, I can turn it probably 90. But I'm not interested in O on A movement. I'm interested in the column. How does the whole column move, not the O on the A? That's what this, or the A on the A. Most rotation on humans in the head and neck comes from C2, C1 to C0, 70%. So if someone tells you, well, Mike, I had a fusion at C5-6, so my neck's not going to move much, I'm going to go, who told you that lie? Because there's not a lot of rotation that occurs at C5-6 anyway. It's designed to rotate, but only a little, and each one adds up to a lot. But most of the rotation is at C2, C1, C0. Just keep that in mind. But I'm not even testing C2, C0, or C1. I'm testing the whole unit. That's what I want to know. You can be all thumbs with this test and do a fairly good job. We play around with it all the time, James and Mike. And we're like, how does that one? Compare yours to mine. Yeah, that seems about right. Yeah. We're trying to calibrate ourselves. So let's watch the next test.
Okay, so this would be cervical. So this is mid-cervical lateral flexion with a skeleton. So the web space of my hand is on the mid part of the neck, and then the base of the skull is held in the other hand, and I'm literally just bending the skull, or bending the neck around the web space of my hand. So I'm literally, if I take the skull off, all I'm really doing is seeing how well the neck bends to the left, like that. So this...
Here it is on the human.
All right, so this is mid-cervical lateral flexion. The web space of my left hand is coming into the mid part of her cervical spine. My right hand is cradling the back of her head, and I'll be blocking here and bending her neck to her left, and this is about 15 degrees of mid-cervical lateral flexion, maybe 20, and then I'll come back to neutral.
What do you think
Got
the
it.
normal range is? 30. Class dismissed. So you got to have a decent ability to lordoze, 30 degrees of cervical axial, 30 degrees of mid-cervical lateral. That's it.
If you have that, you have a patent airway.
Yes.
That's how we assess airway, right there. I know there's a lot of ways to do it, but that's just a different way to do it. I want to share that with you.
It's a nice way to say, can your body give you an airway? What if you orthopedically expand an airway? Can the body receive that?
Maybe.
Maybe not.
It can, but it may not.
All right.
Let me punch past this. So there's a ton of studies that outline mandibular mechanics, body posture, tongue position, TM dysfunction, mood states, and anxiety influence abilities to maintain balance control in healthy human subjects. Neuroscience letters. Gangloff said dental occlusion modifies your vision and posture stabilization in humans. Neuroscience letters. Helsing said the relationship between craniofacial structure, head posture, and spinal curves in 15-year-old children, and there is one. Christinelli, malocclusion, body posture, and TM disorder in kids with primary and mixed dentition. Awesome study in the Journal of Clinical Pediatric Dentistry. Body posture, malocclusion. Fujimoto, changes in gait stability are induced by altering mandibular position.
That was 2001, y'all.
Oh, yeah.
Look at Christinelli, 1992.
That's back when Christ was a corporal. I mean, that's a long time ago. Let's go further. I was in the Army. So, Lund, postural activity and muscles of mastication with subjects in an upright, inclined, and supine position. Scandinavian gentle dental something or another. Sforza, love this one. Occlusion, sternocleidomastoid muscle activity, and body sway in male astronauts in cranium. Who knew? Lip hold. There's a relationship between thoracic, lordotic, and pelvic inclination in craniofacial morphology in adults. That sounds kind of Rothbart-like. Hruska. Influences of dysfunctional respiratory mechanics on orofacial pain. 97. Dental Clinics of North America. Cuccia and Cardona. The relationship between the stomatognathous system and body posture. 09. You see, all these things are coming from different journals all over the place. There are dozens and dozens and duddies of studies that validate every single thing I'm telling you and that James is telling you. Forward head posture and its effects on airway patency, both mechanically and neurologically, the military neck. I want to cover this, and this will be a breeze. So I'm going to talk about why people clench in the daytime. Here's accessory muscle of respiration called the sternocleidomastoid. Scalenes. Upper trap. That's an accessory muscle of respiration. Secondary muscles for accessory respiration. These look familiar, right? Oromyofunctional therapy guys. So the mandibular diaphragm batch, the suprahyoid muscles, the infrahyoid muscles, there they are. Oh, I want to go back to one. The omohyoid, he's my favorite. He kind of comes here and attaches to the scapula. He attaches to the scapula. Wait a minute, I want you to remember the scapula drawing. What do you suppose that does to the hyoid itself? We talked about an elevated hyoid or a depressed hyoid. What about an elevated hyoid on one side? It's a 3D bone. How about a hyoid? We know it looks like a horseshoe. Here's the left side, here's the right side, here's the back, here's the front of the horseshoe. There's my hyoid. It could be up and back. Wait, no, it'd be up and back. That's up on one side and back on the same side. That's weird. Which hyoid do I fix? The right or the left? Right? I got to get the scapulas in position. But how do I get the scapulas in position to fix the hyoid? Exhale. It's the Whitney Houston movie, man. We're waiting to exhale.
So if you don't, you can do myofunctional exercises till the cows come home. But the scapula's gonna be the hyoid.
Yeah. Your new hyoid is your scapula, which is really your rib cage, which is really your diaphragm, which is really your obliques. On which side? On most people, not always. Then you've got the tertiary muscles, these guys, which is also tongueville. So all of these guys get involved to help with respiration. So imagine all of these guys are on a mission, and the mission is to lift my chest on one side in particular. Can you guess which side needs lifting? Yeah. So now I'm going to activate, and I'm going to use all of these anterior muscles to lift this chest. But all of those anterior muscles attach to the hyoid or the jaw or the base of the skull. So how am I going to support the work that these guys are doing? Who are they pulling on? They're pulling down on the jaw or down on the tongue, right? Because I got to anchor to lift this chest. So what am I going to do to oppose that? I'm going to use this guy, and I'm going to use this guy, because they're going to help keep my mouth shut hard while I busy myself with the act of hyperinflating my rib cage. And I'll get so good at it eventually I'll have both sides up. And I've got great, everybody tells me I have great posture. And I've got a flat mid-back. I should have a 30-degree curve, but I don't know that. I've got great posture. You can put a book on my head, damn it. You won't even see either arm move when I walk. This posture, it's great. I hurt like hell, but I've got great posture, and I clench my teeth during the daytime, especially on the right, and I've got crushed, broken teeth, and I've got dentists fixing one at a time because they only thought I had one tooth when I walked in, the one they needed to fix. I brush my teeth. That would be the effect, a downward vector of pull while I'm struggling to lift my chest. And that downward vector of pull has to be mitigated by increased activity of my masseters and temporalis. The upward vectors of pull on the chest by the accessories creates downward vectors of pull on the mandible as well as the tongue. Increased activity of the accessories with subsequent tongue and mandibular depression forces now in play results in increasing activity of mandibular elevators. These would be the masseters and the temporalis. Sometimes I do a little test. It's a Mike Cantrell garbage test, but I do it anyway because it's fun. I'll tell patients, lean your head back, tap your teeth. If they do this, I know they can't bring their jaw to the top. They have to pull their head down onto their teeth because this is so restricted. So they have a tongue tie, or are they just busy lifting their chest? Kind of makes you think, doesn't it? That's all we want to do is just think. Okay, so now what we're going to do is start thinking about, well, let me do this first, and then we'll talk about it. All right, so gain an ability to identify various postural considerations and understand the considerations to guide when a patient can enter complex dental care safely. First, know that everyone has postural issues. Have these issues reached a point where they're damaging the human? They'll tell you, if you ask. Do you clench your teeth? Do you grind your teeth? Do you snore? Do you have headaches? Do you have neck pain? Ask whatever you feel comfortable asking. Right. So ask what you feel comfortable asking. Ask about their knees. Do your knees hurt? Does your low back hurt? Do you sleep well? That's we all ask that, right?
We have a little checklist of different things you can look at. It's in your folder. And we'll assess a patient together, and y'all can play off that checklist. As you increase your knowledge, that checklist will become more detailed. But right now, it's more important that you're just aware. So it's a nice little checklist. You don't have to check all of it, you check some of it, but just use as your playground as you come to see more and more.
So don't be afraid to ask questions. You don't have to ask them if they have urinary incontinence. But if you feel like asking, ask. Some of them are going to go, you know, I really do. If you're bold enough to ask that, ask it of your TMJ patients. Because I will tell you, every pelvic floor patient has a TM dysfunction. Not every TM dysfunction has a pelvic floor problem, but every pelvic floor patient has a TM dysfunction.
So basically every woman who's given birth and has a leaky bladder.
Has a TM dysfunction.
Yep.
Yes.
Okay, you just explained to me.
I love it. Say that
That's why
again.
we see more women with TMD and men are not the
Yes.
usual suspects.
If you're bold, you can say, sir, do you have testicular pain? Testicular pain manifests itself. Well, the pain of pelvic floor dysfunction manifests itself in testicular pain for men. Do you get blue balls, buddy? That's the question we'll ask. Like, we're in the room, do you get blue balls? They're like, that's testicular pain in guy talk. Yeah, my left one kills me all the time. Really? It's not because I'm not having sex, I have sex. Do you have pain during orgasm? Yes. Women, do you have pain during orgasm? Well, yeah. I'd like you to start wearing these sneakers. Like to bed? That lady asked me that. I'm like, well, just lace up for foreplay, I guess. But I just need you to put these sneakers on.
The story about your patient.
So this one lady came in, pain during sexual intercourse. I needed her to get in some sneakers. She got in the sneakers, and then she returned, and she said, wow, this is great. I'm like, we're shagging, and it's awesome, and I have no pain. And I was like, that is fantastic. Whenever I start putting on my sneakers, my husband's like, oh, it's on. We're doing it. And I was like, really? She said, yeah. Great story.
That's too funny.
She's like, I can't thank you enough. I was like, just don't holler my name.
There's a shoe list in your folder as well. So
It's hilarious. Okay. We're fond of using terminology of like, let's have the patient earn the right to be a true dental patient. That means let's get them neutralized. Let's neutralize our evaluative findings, enhance the mobility of each patient such that the mandible and the body are now free to move left and right. We can know this by assessing the rest of the body on a table. Often we see bite distortions when the body was repositioned to neutral, which is objectively assessed. These same bite distortions are otherwise not visible or less apparent. What I mean by that is they have a habitual bite and a neutral bite. Yes?
Tyra was saying, I wonder what happens then with women who've had hysterectomies and stuff. And I'm like, well, I imagine that pretty much any abdominal surgery is going to cause issues. Because
So you can vary this in any way you like. Like, for example, what if a woman has a hysterectomy? What if a woman has an amputation of one leg? What if the woman comes in with and is deaf in one ear? What if the woman comes in missing an arm? Every single one of those is a loss of a body part that was participating in life for them for a long time. And now when they lose that body part, they immediately have to compensate. What if the amputation was a tooth, as in my case? So there's all sorts of things that can happen along the way, and life's traumas begin to add up, and they start twisting in a new pattern because of those traumas. And then it's up to us to sort of decode those. But we all have a habit of decoding based on our learning, right? The tongue therapist in the room, it's always the tongue, right? And you know, the foot guy goes, it's always the feet, you know? And what we need to understand is, like, I know when I took my very first pelvic floor course, man, every patient that walked in was a pelvic floor patient. I just knew it. You know how that is. Right after the course you've been in, like right now you're going to go back to what you're doing on Monday, and you're going to be looking at everybody with this prejudiced eye now, you know. But not everybody needs all of this, right? So you have to kind of pick and choose, pick the easy patients first. But, you know, so wherever our learning is, that's our wheelhouse. That's our mothership that we're clipped to. And what we're doing is like kind of boldly asking you to leave the mothership for a little while. And I realize that that's daunting to sit here and ask that of anybody, especially when we're saying, hey, dentists, be body people for a while. And it's kind of like, I don't want to. But it's like, you know you have to. Okay. So there are things that we, James and I, encounter all the time that upset our little treatment apple cart. And these things you see here, like chronic hyperinflation and ventilation is probably my #1 disruptor. Now, what I mean by that is I can have everybody in here become that. Everybody take a giant breath in now. Inhale deeply. Hold that breath. Now I'd like for you to inhale. You're like, wait a minute, what? So you can relax. So now imagine your patient is going through life like that. They have a bolus of air in their lungs, and now they live life. I'm waiting for you to exhale, Mrs. Jones. I did. Did you hear it? That's all I got. Where's the rest? Oh, you mean like really exhale? Yeah. No, Mrs. Jones, that's not really exhaling. Lay on your back. I'm going to guide your ribs down. Like, holy mackerel, I didn't know I had that in me. I said, well, we did. We knew that was in you. And so can you imagine, Mrs. Jones, what I'd like for you to do is breathe out and now pause for 5 seconds. Okay, sure. I'm going to help you breathe out. No problem. Now pause. Okay. Mrs. Jones, do you realize you're breathing right now? No, I'm not. James, video her. Now don't breathe this time. Okay. Video. Show video. Oh my God, I'm breathing. Yeah. And you don't even know it. Now this time, promise me, you're going to breathe out and not inhale. 2, 3. Oh, I got to inhale. 3 seconds, that's all you're good for? Konstantin Buteyko, who developed the Buteyko breathing method, said we need to be able to breathe out and pause for like 20 seconds without the need for an inhale. Then we'll be considered reasonably healthy. What? Mrs. Jones can't even breathe out. That's all she's got. If you inhale, deeply inhale now. Go. Got it? Clench your teeth. That's a position of power right there, baby. Fully, fully, fully exhale. Get it all out. Get it all out. Get it all out. Clench your teeth. That's just not right. Nobody clenches here. It's not a clench place. I want to be on the tightrope, crossing the Grand Canyon with a bolus of air in my lungs, clenching my teeth. This is me in life. This is your patience in life. If we could just get them to exhale, get them to stop chronically having a love affair with air, they wouldn't have a low-lying tongue. I didn't say tongue tie. There's tongue tie. Facial dystonias. All of these are things that mess us up. Do you see a lot of head and neck stuff on there? Yes, it's all over the place. Molars and deep bites and cross bites, parafunctional habits, bruxism out the wazoo. Sagittalized people, meaning extended people, are chronic hyperventilators. They rupture Achilles tendons. Just saying. Neither leg will cross midline if we tested it. They're doing weird compensatory stuff. It's got a name and it's not that horrible. You just have to understand it and deal with it. And get the beast called air out of the room. Yes. Yep, I'm pushing it now. Let me back up because now what we're going to do is break into our lab. So didactic is done. So what I want to do now is let's set up this other.
I have the photos of her.
Okay. All right. Do you want to? How do we want to do this lab? James, go ahead and grab that table and set it up. And how do we want to do this lab? Do we first want them to do?
I actually want to do. Let's do Rachel first, and then you'll do the objective testing on Rachel.
Okay.
Then when they visually see on Rachel, I think it'll mean more when they get hands-on.
All right, so let's pop in the flash drive. James, you can set that table up. We'll have it off to the side. Hang on, right here.
You see.
Yeah, that's a good idea. James, you want to do it? Sure. You can bring it out here once they've done it. Once they look, we'll bring that board out here. Are you wanting them to literally fill this out?
Yeah. You want to get it all the way down? I guess all of it. I mean, my shoulder have to go. But if the shoulders right. But if your shoulder's down, that's going to come down with it, right?
And how are we doing time-wise? What time is it?
It looks like I've had a stroke.
We're killing it. Yeah, no, okay. We'll find out. That's my guess.
No wonder why you're having that.
Followed that sphenoid. Okay, so I'm going to rotate it right. So I'm just going to be straight. Opposite that guy. He's going with this guy. So when that happens, there's a driving force on the left side of this maxilla that causes it to move in. Like that, in the frontal plane. That creates the internally rotated left palate that's following this sphenoid. Here it is. Here's the left side of the sphenoid. Here's the left half of the palate. When this sphenoid goes that way, the palate is doing that. It's tucking in as it goes. Got it? On the right side, it's untucking as it goes. Got it? Yes. I'm dramatizing. It's not this bad, but for illustrative purposes, this position can cause a visible cant that can cause these teeth to be up and these teeth to be lower. Or the teeth are torqued out. Yes. So now this position with the mandible, now here's the mandible. The mandible is going this way, and these
tectonic
Yes,
plates.
they hit there first.
Tectonic plates, where it's just like, okay, so you start rotating and it goes up, and so then you're gonna have this like mechanics.
You can have on the left side in the premaxilla, these front laterals are going to be pitched out, and then the right side they're going to pitch in. But her teeth right now, she's doing a stunt on us right now, right? So she has tipped in her premaxilla. So I'm curious to see what we're going to see in her. And there you go. So now we're curious. I'm curious what we're going to see in her palate. Because she looks like she's trying to train toward cross-site right here. So we're like, WTF, what's going on? Is she that dedicated to that right side? She's bringing the whole unit in? That's the IR side. We think that this side would pitch out into premaxilla, but it's not. It's going in too. Plenty of people do.
Over time, and then these used to be perfectly straight, and they just rotated.
They're pronating more on the left than they are on the right. Their right foot is a pronator wannabe, their left foot's a supinator wannabe. So watch my feet.
Yeah.
I'm in my right hip. My right foot wants to pronate. My left foot wants to supinate. To let me get over there. My right foot's dying to do that. Some people will be here and completely collapse the right foot in. They've created pathology in the metatarsal joint. So now they got laxity in that anterior talofibular ligament as a result of that. So the responsibility now begins at the ATFL on the right side that's now collapsed. So that person is dying to sense an arch. Sometimes we can take and just give them a feeling of an arch by shoving some Kleenex in their shoe. And all of a sudden they increase cervical axial rotation. When you feel that reference. Uh-huh.
Okay.
I buy it.
We gotta roll.
It makes sense to me, especially with your mid-face being asymmetric like that. You would need that. It would make sense to me because that whole left cheek comes at me. Your right socket is back. There it is. I'm looking at it.
Right. Problem is,
This eye's closer to me.
But then it's never comfortable.
I'm done.
what do we want to know about Rachel, guys? What do you guys want to know about Rachel? Rachel, did you play any sports or did any physical activity?
I did swim team and kind of cheerleading and horseback riding.
Okay. Rachel, why don't you give us a little background about yourself, why you're here today?
Okay.
Rachel, do you mind if I write some of the things you say just by way of bullet points?
Not at all.
Is that
I wrote
okay?
the book.
Okay.
Yeah. Sorry, I don't. You're right. It's hard. Should I walk?
Right, you don't know where to look, right?
No. Yeah.
You're good. Just do it right there.
I don't know what I need to share. And I have a problem with oversharing.
Okay, we'll guide you.
Okay, yeah. Well, I guess like I had mentioned this morning, on a personal level, I'm aware of airway. I don't feel like I breathe well. I constantly have a minor amount of congestion, whether I'm sick or not. I did have sinus surgery to correct a deviated septum, and then
Which way was it deviated? It's all right. Go ahead.
yeah, I don't remember. And then they did reduce the concha or turbinates. And it did help. So I went from an AHI of 14 to 9, supposedly. But I'm still tired all the time and I still snore, but it's better.
Cool.
And yeah, the anxiety, I take anxiety.
When did you have the
medicine.
deviated septum? Sorry, I'm obsessing.
Fixed? When did I get it fixed?
Yeah, when did that
Last year? Yeah.
Huh? What?
Yeah, maybe a year ago. About a year ago.
Is that better?
Yes.
Okay.
Maybe less than a year even.
Okay. All right. When did you start noticing your teeth were moving?
In the past 4
Okay,
or 5 years
gotcha.
maybe, or maybe before, I don't know. I think it became obvious in the past 4 years because I started scrutinizing pictures. And I only notice it truly in pictures, but now I can see it more in the mirror.
I got
And
it.
I can feel it.
Yeah, you can intuitively tell, you can feel it. And when did you start noticing that you were having like the respiratory issues of, like going and getting sleep studies and all that kind of stuff? When did you first start doing that?
Only working with Dr. Scott. and
So, like,
Lenny
in the last two-
Yeah, last 2 years.
Last 2 years? Because that's that good intellectual curiosity. You just want to
Yes.
know, well, hey, let's test me. I want to see.
Right.
Got it. And then
Once
somewhere
you
along the
learn about
way.
it, yeah, you hear about it and you go, ooh, what about me? Or actually, I think it was, I read The 6-Foot Tiger with the 3-Foot Cage, and I'm like, he wrote this book about me. I'm sure
Right.
everybody feels like when
Isn't
they
that a
read
great
it, right?
I love that book.
Yeah, yeah.
I had the luxury of having him in one of my classes. It was a lot of fun. He was just a good guy. Asked some great questions too.
Yeah.
But anyway, so
When
sorry.
did you have your first ortho?
As a kid, I 6th grade, 5th grade, 6th grade, 7th grade,
And how many
Yes, middle
orthos?
school.
How many orthos did you have?
just once.
Okay, all right.
Yeah.
She
They
said
did
she
have
said
to,
first.
they
I
had
was
to
like,
surgically pull down the left canine, 11, with the chain.
Did you walk earlier than 1? Do you know? Are you aware?
Yes, I think I walked early.
So you're an early riser.
Yes.
Have you had any like traumas, car accidents, falls, anything like that?
No, nothing major. I think I've had a couple small fender benders, but nothing, I mean, I don't think it did any whiplash or anything like that. I don't think so.
And you said she was an early riser? You were?
Early riser.
I think so.
And
Think-
did
I
you
think I
nurse well or did
remember
you
my
not?
Are
mom-
you a baby bottle or are you a breastfeeder?
So I'm adopted, so it was bottle, but my mom tried to breastfeed, but it was still through some kind of a weird contraption because she didn't have me. Yeah,
Oh, how cool is she?
yeah, she's very, as a single parent. That's a whole side issue.
That's completely
Yeah, she
badass
adopted
right
me all by
there.
herself.
You gotta love that.
Rachel,
That's
any TMD?
So my jaw absolutely pops and clicks all the time, but it does not hurt.
No pain?
No pain.
No headaches?
Headaches, yes, but I didn't, again, I kinda,
She doesn't like
Don't sleep well.
no.
Don't get in your
I
routine.
feel like I sleep fine and I sleep a lot, but I never feel rested. I'm always tired.
And you have a little bit of anxiety. You don't have deep,
Definite.
deep,
Definitely anxiety.
nightmares?
No, not too bad. I used to feel like I didn't even dream much, and I've been having more dreams recently.
and when you tap, what hits?
I feel this side and here.
So basically, the laterals up front on both sides.
Well, the molar's on the left side.
Ooh,
I feel
okay.
those.
So you do manage to find some molars on the left side, and you're in crossbite on both sides, or in the right side for sure.
Well, I'm not full crossbite, am I?
I don't know. I'm not a dentist. I just pretend to be one. Let's ask a dentist. Are there any dentists in the room?
Probably take my fingers out of my mouth. But yeah, no, I'm not full crossbite, but I might be close to end on end, yeah.
Okay, yeah. So you're at least headed in that
Tell us about
direction.
your vision. What kind of glasses do you wear?
This is her favorite
My
position.
vision has been,
Yeah, I've been watching.
it's mild, I think it's -1, but I've fluctuated between -1 and -1.5 in both eyes.
Yeah.
They vary, one eye will be a little different, I don't know. But that's been the same, and I think I got glasses
That
again in
was-
6th grade.
I don't remember when I took that, but it was sometime earlier
No.
today.
Just
Or it might have been last
They're
night.
single lens vision.
single lens vision.
Michelle, she's
And I
doing it now.
can't see, I mean, it's distance, I can't see distance, it's blurry.
This is how she likes to hang out.
How are your hips?
So you see how she's orienting
They're
herself
fine as
into
far
her
as I
rib
It's like you
know.
guys
cage,
can start checking off
dropping her
checklists. How are
right
your
rib
hips?
cage down.
They're fine as far as
Filling
I
up her
know, I
left
don't
rib
tend
cage
to have
with air,
trouble,
crossing her
except
left
I
leg
do,
over
I
her
side
right.
sleep, and there are
And she's
times
doing
when
it
I'll
now.
wake up in the morning,
Got
and
it.
when I'm rolling over in the middle of the night, my hips will
So
hurt.
this is how she likes
So
to
I do
hang out.
put a pillow between my knees
So when we
usually,
were doing the introduction, it was just
and if I forget
your
that,
hips
painfully
hurt
obvious
on
to
the
James and I. We're
sides?
like, let's just get a quick picture.
Is that what you're saying when your hips hurt?
So
only if I'm, like, only when I'm sleeping and I'm rolling over. There's
Okay.
just like this pain to roll over, and then it kinda goes
Knee
away.
issues.
They pop, but they don't hurt.
They pop?
They pop.
Which one?
Left more so than right.
Okay. Where does it pop? To the side, laterally, or medially?
In the middle.
In the middle, okay. For quads.
Yeah, it's right in the middle.
and
How are
one side
your
worse than the other?
This one's worse than that.
Gotcha.
How
Foot
are your
pain?
ankles?
Can I get a picture of your palate?
Uh-huh.
Yes.
Figures I'm gonna buy a horse. Okay, hold that pose.
Sorry if there's food in there.
No, that's all right.
give her a carrot.
So we'll let the myofunctional therapist,
Any
where's our,
ankle issues?
Not
Oh,
that
there
I'm
you go.
aware of. I haven't.
you want to look first?
I mean, I have twisted
Fasciitis? Like
So she's got
bottom of the
some fairly
feet.
prominent rugae and a scoliotic tongue.
Bone spurs. Bunions?
Oh, I had
That's a tongue that has violated the law.
In
I
the
don't know.
foot.
No, like I had random bone spurs come out in my mouth. Like and this was 5
Yeah,
years
baby.
ago, and I had my
She's
wisdom
a-
teeth taken
She's
out.
at
when I
very
was
least
16.
behaviorally is.
And I thought that was really weird.
So
It was on the right side.
Anything under your feet?
Right.
Bunions?
So that tongue is not spending a lot of time visiting north, is it?
Not yet anyway.
Lower back issues?
Mild.
So that's right out of the gate.
I
We
have
talk
some
about it.
Sciatic
Work.
nerve issues?
Let me know if it goes dark.
When you were pregnant, you had sciatic
Yeah, I
nerve?
haven't even
Since
looked at
then,
her palate.
Not really.
I was just looking at the
Maybe every once in a
rugae
while
and the tongue. I was
you'll
like,
hear
okay.
a tinge and it's on my right
She's
side.
IR'd on which side?
So your sciatic nerve issues are on
This
the
is
right
left, this is
side.
right.
And where do they radiate to? The back of the leg, the side?
Left, exactly.
So it's to the back of her hamstrings down to her knee.
Look at her tongue.
Oh, I have a
Look at the
tongue
roof of her mouth.
Right
And look at her IR palate on the left.
Yep, right there, right there. Yep, right there.
Yes, ma'am. She does do that, doesn't she?
Between your shoulders.
I care about it.
Between your shoulders.
She's got a misbehaving
Any
tongue.
issues
She's got
between your shoulders?
definitely.
Shoulder blades?
It's against the law.
Oh,
She did it for a reason.
We'll get that. We'll work our way up.
She's
I
at
like
her shoulders. One thing I haven't heard you mention either, where's your resting posture of your tongue?
Well, we haven't worked up to the head yet. She's on the shoulder.
I'm pretty sure it's down
Usually go
in
from
my
the
mouth.
toes.
It's down.
Yeah, I don't think it gets to the root
We'll
of my
validate
mouth
that.
often. But I'm very unaware of my
Okay,
tongue.
so look at her palate. IR on the left for sure.
Shoulders,
Her left.
shoulders. I don't.
Do you ever feel like
Prominent
you need to
rugae,
stretch?
Oh yes.
midline fissures on the
Yes.
tongue. I'm gonna go down south.
This side will hurt more.
So her right tracks?
Yeah.
Right track?
And I went and got a massage one time, and I for several
Oh, you
weeks
nailed it,
I had
baby.
a
That's
very
right.
specific headache right here.
Yep.
It got to
That's
that
it.
muscle in my neck, and the
And
pain
so it
shot
doesn't
up
make
right
you
to that
wonder,
spot.
'cause we're gonna do another
And
bite
that's all
picture in
right
just a
side.
minute, because it makes me wonder what her
And I
mandible
just
is
assume
doing.
it's because
Right
I have
between
bad
your
posture
shoulder
when I
blades.
work.
If it's IR to left, it could
Not
be a
too
side bend, could be a
bad.
torsion, right?
Sometimes.
So
I
we
did
haven't
have,
determined whether or not she's a torsion or a
So I
side
did
bend.
have a
Remember,
breast
everybody's a
lift
side bend, so we know
and
she's that, but did she
implants
layer another
placed, and
compensatory
after that
strategy on
surgery,
top?
Terrible pain.
She's got an
every
IR
time I
palate
showed
on the
her.
left, prominent rugae in the roof of her
Like that
mouth,
was the worst part of
which means her
recovery
tongue's
for me,
not
was
spending
that
time
pain
up,
between my shoulder
and
blades. But other than
that
that
midline
time,
fissure in her
they don't
tongue
bother me.
Hey, Jane,
is
so she did
validating that
have,
as well.
her breast
So the
lifted,
tongue's not
and
spending
she-
time.
the
Can you get another bite picture?
shoulder blades got worse.
No, I'm never gonna show you.
Yeah, she had implants too.
She's the redheaded stepchild of this whole thing. Okay.
Yes, there is some
So
implants
you
in
see the
there.
IR palate on the left side, so the left palate is more internally rotated than the right.
When I
She's
was
got the
recovering, the pain between my shoulder blades.
So, and
was
this
just
side
like,
here
that's what
is
hurt the
steeper.
most.
Her left palate is in internal rotation. She's trending toward crossbite because you see that tooth coming on the left side, but she's in crossbite on the right, so it makes me wonder if she's doing something tricky. And she's biting left. You can also see this fissure in her tongue, which also tells us she's not keeping her tongue up because that fissure wouldn't be there. And then finally, we see the prominent rugae, which means those rugae shouldn't be so prominent. They should be flattened out because the tongue's been spending time. So they're not shaking hands. They're not friends. So part of the program. It doesn't appear to be terribly scalloped, but I do see some mild scalloping, but not like, you know, you've seen a lot worse in this damn thing.
Women who have implants, they don't realize.
Yeah, she had a deviated septum that was repaired.
How it's hard.
Yeah, you want to take a picture of it? You go, girl. Can I get another picture? Okay, so can you just, no, just bite and just move it to, wait, I'm not ready. I just want to shut up with the flash, because I don't need the flash. Oh, the hell with it. We'll just go. And hold that pose right there. You're such a badass with regard to getting your teeth exposed. She's right down the middle on that, so I'm gonna call her a side bend.
Like all the sides are there, but overall I do
You're not a
okay.
weirdo. You're not a weirdo.
Oh, okay. Okay, anything else you guys want to know? Let's, Christy, ask her way about her tongue.
I already know.
Ask her so everyone else can know.
Well, you know.
Well, that was the first thing.
Boy,
I
are you
asked her
selfish.
Before we went here, I was like, guys, where's the rest of your tongue? Because I'm instantly looking at her facial features, and I know her tongue is always on the floor of her mouth, whether she said she wasn't really sure. Her tongue's always on the floor of the mouth because the way the curvature of the lips and everything are already.
And Marilyn, that can lead to a lot of parafunctional extra activity in the lips when the tongue is not where it ought to be.
And then it's just, then the other thing, when you guys were looking at her palate, it's just like you see the prominent rugate all around. You saw a white sloughing on the back of the palate. That means the tongue is never hitting the palate. And so that's residue from where the tongue isn't naturally cleaning it. You can see that on the palate as well as you can see that on the tongue.
And then I have the
And then you have
fissures
the
on the
fissures
tongue,
and
yeah.
the midline groove, and that becomes more prominent with age, with prolonged mouth breathing, as well as tethering from the tongue not able to actually go in the palate. And so it creates more of that central grooving, because that's one of the tongue's natural movement processes.
Yeah, can I come see it?
I want to see it. I want to
Okay.
So, I mean, and then it's like when she did elevation, she's got floor of the mouth compensations and everything. That's just like minuscule.
Say more about floor of the mouth compensations.
It's like when she elevates her tongue and when she talks, the floor of her mouth elevates to compensate for the lack of tongue movement. And so it's another one of those compensatory patterns that is trying to get the body to work as a whole rather than being able to move things independently. Because the jaw, the lips, and the tongue dissociate by the age of 4 to 6. And so she should have that independent movement by then.
Or they should dissociate.
They should dissociate.
Yes, they
Hers has
should
not.
dissociate.
And
So this, I just call it the mandibular diaphragm.
Right.
So that mandibular diaphragm, the floor of the mouth, is becoming busy, tonic,
And so
active.
it's like all of her suprahyoid muscles are elevating and tense, and they don't have fluidity.
Do you clench?
Yeah.
Okay.
James, I don't know if
So-
you got this, but she says she gets headaches from here down to her right triceps line.
Okay, which would make.
Right side here.
So, remember we were talking about the accessory muscles of respiration, and then countermanding that with masseters and temporalis to support the extra assistance that these guys are providing to elevate my chest. So it would explain part of the bruxism activity that you do, that even despite an improved sleep study, that you're still going to brux because you're still busy at least on one side trying to improve respiration. When we were looking, the one image we had here, hold please, with the scoliotic tongue. So I want you to appreciate that the left side of the tongue is higher when you open your mouth just without being asked. We see that right side down.
Right.
I think there's a correlation between which side the scoliotic curve is on a simple scoliotic tongue because there's complex scoliotic tongues. This is Mike Cantrell
I
talking.
know, and I'm sitting there going, I agree, yeah.
It's so cool.
Like,
So-
can you show us the scoliotic?
Yes, so if you, I'm gonna zoom you in so you can just look and you'll see there's a, remember the rib hump we saw on the girl bending over? We just see a tongue hump on this tongue. So the right tongue is up. Some tongues can be complex where you'd have a right tongue hump in the back and a left tongue hump in the front. And sometimes you'll see the left tongue hump in the front crossing midline, which is crazy, right? It's like, how is somebody doing that with their tongue? They can't flip it, they can't do any of the exercises that you guys like to see happen, but their tongue is doing this weird crossing of midline that makes them have two rib humps. Just like someone with a pathoscoliotic spine, they've got two curves in their back, and now they've got two curves in their tongue. And this, but in this case, it's the tongue hump, the flat tongue is on the side that's working the hardest for rib cage expansion. It's kind of cool when you think about it like that. So she's working to try to get that right rib cage to expand. What I'd want to do now
Do some tests on her?
is test her, yes. So how about head here, feet there,
Okay.
and chill. And then, yes, you're in the catbird seat.
You need it.
Okay, very cool. So you're in the catbird seat right there, and Christy, says immediately, wow, it's like the rib cages that we just saw in the video, right? Yeah, there you go. Yes, exactly. This side, this rib cage is up. So as I palpate, so if you take your own hand and put it right here and just be a casual observer, and now take this hand and put it there and be a casual observer, what do you notice? Yeah, wow.
You guys, you're here, you come and look down her this way. Right. You can really see, or come look that way.
And the more you kind of shake hands with your rib cage. Oh, Julie has a question. Isn't that interesting? Yeah, so we're going to talk about that in just a sec.
Yeah, you can really see the pictures going right. Actually, the left side.
Yeah, biotensegrity is such a badass concept. And you're witnessing it.
I know, that's where my children are.
Yeah, and I know you've read that ALF approach book that Tasha Turzo just wrote. Oh, you need to read it. She goes all into it. She's having fun with it, yeah. She's an osteopath. Well, hang on a minute. We're over here talking about you behind your back. So one thing that a couple of us had noticed was this larger right quad. So the larger right.
Yes. Sorry.
No, it's all good. So she owns a right hemisphere. And you know, if James was talking about this, he would say in James's tone, he would say something like, no, she's really over in the right hemisphere. She's out in this position, and then she's taking the entire system and rotating it back. So that's what you're doing. You have a right leg and a left kickstand, right? You've got a thorax that's abducted away from midline to the right, which is flaring these left ribs. When I first palpated your rib cage, for a half a second there, I thought she had a pectus excavatum. So a very, very small or large indentation in your mid-chest right here. So there's pectus excavatum would be an apple cart upsetter that I didn't even put up there, but a pectus excavatum. You've seen folks who have an indented chest. And pectus carinatum is an outdented chest. Pectus excavatums have extremely restricted abilities to expand AP in their chest. And pectus carinatums have extreme difficulty with expansion laterally. And both pecti, is that a plural? Both pecti overuse their necks to pull air into now a doubly restricted rib cage. Make sense? So let's look at our objective tests. So the three neck tests that we're exposing you to. Now you have to remember there are multiple tests. We would use these two appendages to assess this pelvis. We'd use these two appendages to assess this rib cage. And we'd use this appendage to assess the rib cage and occlusion. So that's what we're going to look at, this appendage. And these two appendages, one test here and three tests here, because that's quick, easy, down, dirty, and you guys can rock that in a dental chair. So she's chilling, laying here like this. I'm going to do this cervical lordosis test, which is really when she exhales, I might ask her to inhale and then exhale. And then I'll lift in the middle. And I feel a moderate lordosis better than I expected. Kind of nice. It's almost like Tammy's. What did you see, Christy?
From here, because we can't see the curve, all I do is see her.
You saw rib cage movement, didn't you?
Yes.
So, and remember how Tammy's looked? So Tammy's was the same way. We saw that rib cage movement, right? Whether you want to be on the spotlight or not. So it's like, we lifted Tammy in the video, and we saw that rib cage kind of do something. And that's what you just saw, and I see it here, and I was like, it's better than I expected. It's about like Tammy's. So we'll call this Tammy-esque. So moderate, and that's the most subjective of these tests, right? Because it's sort of mild, moderate, severe. It's kind of like when you're getting these radiology reports from the MRI. They always use mild, moderate, severe. It's kind of like, I want to know more, but that's all you get. Let's look at cervical axial rotation. So first, we start by styling the hair. Chill.
Okay.
Don't be helpful.
Okay.
She's got 5 degrees of cervical axial rotation to the left. If I'm generous, maybe 10. Your head goes further.
Right.
Your neck stops there. Boom, boom, boom. She's got to the right, oh Lord, 30. So I want you to appreciate that difference. So let's go. I'm driving, chill.
Okay.
All right, so here we go. There's the end. And appreciate that compared to that. There's the end.
Yeah.
So there's quite a difference. Yeah, when I go that way, it just doesn't go.
Right.
So now let's look at mid-cervical lateral flexion. So there's my web space. Remember the video. Blocking on the left side, relax, cradling her head, bending her left, don't help. She's got almost 30 degrees. We'll call that 20 to 25. And look, there's less here. So mid-cervical to the right, we'll call it maybe 15. Mid-cervical left, oh wow, I can go almost to your dang shoulder. So 15 to the right, 30 to the left. Tell me how come it's limited going to the right.
Well, that's the crazy side. It's taken so much.
Well, you can't just say that's the crazy side. I need more than that. So I'm gonna mimic the position. So I'm in my right hemisphere. I'm rotating my cervical spine to the left. We already know it doesn't go much further left because it's already gone left. I'm bent to the left. It should go to the right because you're bent to the left. If anything, it wouldn't go more to the left. Here's the rub. When I begin to take it right, these muscles called scalenes are busy and short and tonic, holding the left rib cage up and restricting right lateral flexion A. B, when I take her left, she gets normal coupled movement to the left, meaning transverse processes rotate into the curve normally. But when I take her to the right, it's a jumble. It's anybody's guess. This one could be rotating the wrong direction at C4, C5 could be going here, C3 could be going here, C2 could be going here. We don't know. What we do know is if there's a restriction in right mid-cervical lateral flexion, on a young person who we know does not have arthritis in that neck, and if she does, it's so mild we don't care, why does she have a restriction in axial rotation and mid-cervical lateral flexion? In any direction. She shouldn't. She's got if anybody should have it, I should have it. I'm a broken down old heap. She is doing pretty young here, so she should be able to rock this. Let's look at the last test, which was the first one you saw up there, arms. So what we would expect is about 90 degrees on this side. Let's look, because she might be throwing us a curve. We don't know. We just expect it. I'll park a Buick on her shoulder and internally rotate this. Oh, there's a slight limitation here. She's throwing us a little curveball. This is, call that, James?
85.
Yeah, we'll call it 85. Let's check this side. And you feel me taking it way to end range.
Yeah, it was, yeah.
Park a Buick here. And what are we going to call that, James? I think it's 47 3/4. All right, so let's first place her body in neutral, okay? So we'll start at her neck. So what we're gonna do is we're gonna take her, and now, is her neck in neutral now? She's looking at the ceiling. I'm thinking no, because we know she's already rotated left and we have no idea what she's doing in mid-cervical lateral flexion. So we're gonna put a little lordotic curve in her neck, and we're going to orient her neck to the right. Right there. That would be neck neutral. A lot of times that can inhibit things, and we can get 90 degrees. Isn't that just whack? W, T, and an F on top. Okay, so now put your head back neutral. Let's put her in neutral a different way. So, yeah, I got them. I'm looking for something more high tech. This will work. Oh, these will work even better. Okay, so we're going to take a high-tech device. This is called a pelvis repositioning device. So what we're going to do, hike and come on back down. and
One
relax.
side. Okay.
So what does that feel like to you?
Awkward.
Yeah, I've kind of shoved you that way. So we know that if her left temporal bone is forwardly rotated and externally rotated, we know, James said, that her pelvis is in the same position on the left side, which means that her sacrum, her tailbone, is oriented to her right. If I do that, I can orient my tailbone, x-ray vision, at 2 o'clock. Got it? I'm chillaxing in my right hemisphere. I haven't done anything with thorax. Let me rotate back to y'all. So now in this position, my tailbone is oriented to 2 o'clock. Got it? I just took this pelvis repositioning device and oriented her tailbone somewhere other than 2 o'clock, back to the left, at least passively. What we're curious about is, did that make any difference? Isn't that weird?
Yeah.
So we're going to take that away. So it would have the same effect cervically, we think. We don't know. We only think. In other words, can we create effect here that would have enough profound effect into this cervical batch of muscle that we were talking about earlier, right? So the next thing we could do is maybe take that. Now you make...
Just one?
Yeah, just one. Right now, go ahead and lay with your head straight and tap, tap. And what makes contact there?
I feel,
Somewhere up front?
yeah, 6, and then my molar's on the left.
Let me modify it for a moment. So I tell you what, don't do anything. Let me check this again. Just to make, okay, so you're back limited, just making sure. And let's modify you for a moment. So what I'm doing is I'm holding the back of her left occiput. So the back of her left occiput is a reference that she lacks. In other words, if she's laying on the table, the back of her left occiput doesn't lay on the table as well as the back of her right occiput. Remember when James was talking about which direction the occiput rotates because that first cervical vertebra is bumping into it. Then I'm going to give her contact with her bregma with my right hand. So this is an osteopathic technique. So now I want you to tap, tap again. And did that change your occlusion at all?
Yeah,
What hits now?
just the molars.
Just the molars. So I want you to tap there a couple of times.
Well, I can kind of change it, but hold on, try.
Be cash. Just be cash. It just changes it, yeah? Okay. Put the stick in between your left molars and make sure they're all covered. Got it? And let's check disclusion there. Now that's better than the high-tech glute hip pelvis assistive device. I like that better. So does this make sense?
Holy smoke.
But let's check, wait, we're not done yet. Let's check lordosis cervical axial.
This changed too?
Well, we want more than that, though. You know, all we're doing is, we're trying to brag, but we want to be greedy. So what I'm curious about now is, what does this do, if it's any better? I'd say it's maybe a little better, but I'm not, like, psychotically happy.
Okay.
But let's check cervical axial. Now, I'm grooving on your cervical axial. That's almost 30, but I'm not giving you 30. We're calling that 25.
Okay.
Because this is our gold, that's 30. That's like Exorcist. Okay. I want to be able to look around and see what's coming behind her, you know. Mid-cervical lateral, 30. Now that's what I'm talking about. So that's like butter.
What is that like?
30, 30, 30, 30. What? 30, 30, 30, 25.
From 15 to 30.
So let's take this away for a minute. And I want you to take a giant breath in. And then breathe out. And I'll pause right there. And then take another giant breath in. Coolo. And relax. So what we want to do is make sure you've ruined yourself before we do any other, because we got to take away variables, right? So you're back at your old bad self again. Now what I want you to do is drop your arms by your side. So let's assume that This positioning problem is everything we're claiming that it's cracked up to be. Let's just assume that because it may not be, but we sure think it is. So this body type and position, we've got that externally rotated rib cage there. So if we said this is a warehouse that receives air and this is a warehouse that receives air, which warehouse is closed for business, this one or that one? Right? Right. So let's open the right warehouse for business. So we're going to open the right warehouse by closing the left. So take a breath in and breathe out. Playing the role of abdominals today will be Mike Cantrell. So I'm holding down her left rib cage. So I'm playing the role of external and internal obliques and transversus abdominis on the left side. Now go ahead and take a breath in and breathe out. Now that may be easy, may be hard, whatever it is. And as you're doing that, do it again. What we're interested in, especially that guy and that lady, we're interested in how well can she expand apically in her upper chest. We know she can expand laterally. Everybody in here can belly breathe. I don't care about your belly breathing. This ain't yoga. I care about, can you breathe? Take one more and relax. So if she did a good job with that, we should see enhancement of mobility here. We should also see enhancement of mobility here. We should also see enhancement of mobility here. Oh yeah. And here. And here. And here, until she takes her next breath. Take a breath. And she's going to blow the whole show when she breathes. So what would we do at this? All we did was recognize some stuff, right? And we recognized there's some objective ways to change her stuff. Now, when we were sitting here and we were doing the intros, you know, James and I were kind of looking at you going, oh yeah, I mean, like right there's our baby, you know? And then, but only for the sake of a visible left cranial side bend, right? So that left side bend rotation that she has is just nicely visible. So it's a great example. But a lot of people are very clandestine in their presentation, so you have to use objective measures. But in the case of Rachel, she's sitting there with a visible side bend rotation. Do we need to deal with a dog wagging a tail? Or is the tail beginning to wag the dog? And I think because there's a visible presentation here, because some of us are more clandestine about this presentation, and I submit to you, this tail may not be wagging this dog. But once you start seeing enough visible presentation here, the tail is starting to wag the dog. So we know we've got a tail that's beginning to wag this dog. She's telling us I've got some headaches, right? I've got a bite distortion that is continuing to distort. When we take her out of her bite, we see a pretty good resolution of nearly every finding. It's pretty easy. So it would suggest that we need to take care of this tail. Plenty of patients belong to us three that you'll never see. Let's flip that. Plenty of patients belong to you that we'll never see. We don't need to see them. You got them. You're treating them and don't even know it. What we're doing is we're saying, yeah, we have some patients that definitely need your help. And so we would want, what we're really saying is, hey, I got another tail wagging a dog. So can we bring this tail in and can you take care of it so we can treat the rest of the dog so that the dog will no longer wag the tail that started wagging the dog? So in this case, I'm pretty certain we've got a tail wagging a dog. But then what we'd want to do is once we've resolved the tail, we better teach the dog. So how would we do that? What does teaching the dog look like? Some of you are dogs right now. You're patients, right? Mm-hmm. So what happens first is you get co-learning. We're co-discovering right now what's going on with this body. So we're saying, yeah, we see X, Y, Z, elemental P. And you see it too. Yes, I see that. That's pretty cool. So that lasts a little while. It's helpful. Yeah, it's cool. I like that. It's neat. Then what? Well, then we would start on a program. And what might that program look like? The first thing we'd want to do is take you out of your habitual bite. Now, we did a moment ago, we did it 2 ways. Way number 1 was tap, tap, yeah, I feel what I feel. Cradle your head a different way, and all of a sudden we have her in neutral. Tap, tap, that's a different bite. That's your habitual bite, which is all this full left occlusion that isn't what it really is. Let's give you true left occlusion, and all of a sudden now you're completely out of your habitual bite. Because when you're just laying here tap, tapping, you're hitting incisors. And then that's your habitual bite. We give you a little reference, we take you out of your habitual bite and try to get you to a bite that is desirable for us to get you in your left hemisphere. Build on that, make a splint, give her a good solid left reference. In this case, not everybody needs a solid left reference, I promise you. There are patients who need a right reference. Or indexed. Or Tanner's. Or none of the above and just an ALF. Anything. But we need to make sure we're given the right device. Most of them, if somebody said, Mike, I'm going to hold a gun to your head, you have to do 1 device for 10 people, I'd give them all left reference. I probably can't go wrong. Even a blind squirrel finds a nut every now and then, right? I'm going to get it. Then I'll work from there. But the bottom line is let's accurately assess what needs to happen in here. Then we can look at the dentist and go, okay, here's what I think we need. Let's get her in a flat plane, non-repositioning, full occlusal, acrylic, relined appliance, give her a little bit more left referencing than right. Make sure that she's got that good, what do you call that, canine whatever, crossover or whatever. Yeah, cuspid rise. Let's give her all of that. Now let me see if it worked. Let's test her with her new appliance in. Yes, we've got some good neutrality. How far down the system did that splint get us? Does she have negative pelvis tests? We didn't do any pelvis tests. I promise you, if we look at her, we're going to see differences in femoral rotation and all kinds of other things. But how far down did the splint go? Depending on how far down the splint took us, makes life easier for us to treat her. And then we give her those activities. So does this kind of give sort of a layout of how the treatment plan might work in this human? Then we'd say, okay, now let's objectify each visit with more tests. Tests that we're not going to go over in here. Things like with that, you saw the one dude with his foot on my shoulder. Test functional performance tests. Because once she can functionally perform without loss of neutrality, we win. She's not going to have problems. That's the mission. It's easy to get lost in the weeds along the way. So you have to kind of shake the patient. Okay, now, stick with me here. We got a way to go. Oh yeah, we'll do the occlusion test too.
This test is really telling, guys. It's the coolest test. It's called the two-finger test.
So this is an osteopathic test. So many times people, they'll tell you they bite one way. You can test and see just by using your own palpation. So I'm going to put my fingers between her molars. I'm going to say, bite me. Don't bite hard, just close, right? Close firmly. And then, you tell a kid this, and they're like, I'm on, baby. And you're like, get the hell off of me. So she'll close, and then at this point, I'll pull. She's going to hold on to my fingers with her teeth. And then we'll see what happens.
You don't have a latex allergy, do you?
No.
Good, because these are latex gloves. Spoken from the latex allergy. We'll find out in a minute. You look like you had lip injections.
No, I'm good.
Okay. Close, and close firmly. My grandmother closes better than that. Close, hold on to me. Okay, so this is, she's fairly even on this, which is really not bad. So let's relax. Let's you might mention to let go, Mike. All right. Sometimes what you'll see is very firm contact on one side more than the other. What that's telling you is the position of the sphenoid. So not always. So if a person has reduced contact on one side, train the sphenoid on that side. Well, how would you train the sphenoid? The way you would train the sphenoid is by having the person put their tongue to the roof of their mouth, advance their mandible forward. You can do it right now. Put the tongue at the roof of your mouth. Go ahead. Slide your mandible forward slightly and put your fingertips on the right side of your chin. Now press to your left, but don't let your mandible move. You should start to feel a muscle working right in your TMJ area, about the size of a $50 or a quarter, right here.
Your lateral pterygoids right
So that lateral pterygoid you're activating right now on the left side. Not everybody here needs that, Neela. You need it on the opposite side. Don't worry about it. So as you hold and you feel this, what you're activating is the left lateral pterygoid, which is now taking the right wing of the sphenoid down, raising the left wing of the sphenoid, which increases left molar contact. So if I have a patient who's making poor left molar contact, activate their left sphenoid. If they're making poor right molar contact, activate their right sphenoid or their right lateral pterygoid and pull the right wing of the sphenoid up or the left down. So right pulls left side down. Left pulls right side down. Lack of left contact, use the left lateral pterygoid. Lack of right contact, use the right lateral pterygoid, and that'll increase your right molar contact. So experiment with it. Don't let the jaw move.
In order to, when you say use the right lateral pterygoid, you're going to push on the
On
left.
the opposite side, exactly.
Push on the left to activate the right.
So yes,
Okay.
so let's assume that Rachel had poor left molar contact. As I pull, my finger's going to come out. You saw how I was lifting her whole head, right? But I would pull and my left hand would come out. At that point in time, I'd say, listen, let's activate that left lateral pterygoid and then do it again, and then she's going to hang on to me.
Okay.
So it's an easy, good, it's a very objective test because you'll feel it. You'll know because you can actually feel this. So it's a great test for understanding positions of sphenoids sometimes, but certainly understanding ability to occlude on that side. I have concerns that she occludes too well on the left side.
Yeah.
Because why is she doing that? I was going to be convinced that she was going to make contact or was going to have an internally rotated. What just happened?
Trick girl. Take your eye off her, she's a trick girl.
She slammed into the back of my legs a minute ago. I thought she was trying to flip me. But anyway, I thought she was going to make, she was going to have a rightward tracking mandible. But when I took the picture of her bite in MIP, she was midline to midline. That's weird. But then I'm remembering like, okay, she was in ortho. Maybe we've got sort of a false midline to midline. But I think she's trying to be a torsion. That's what I think. She's got bilateral limitations in HGIR. That's kind of torsional behavior. And we'd look at other things, but I don't want to go there. What I'd like to do is break into having everybody do these tests. So the tests, again, humeral glenoid internal rotation. I'm going to explain this. Arms at about 90 degrees of horizontal abduction. Place your hand and a little bit of weight on that shoulder complex, and don't jab your heel of your hand into the shoulder. It kind of hurts. Cup that shoulder, and then rotate down until you feel sort of a natural stop. You'll know. And then that natural stop will change later when we work on the patient. That should be permanently all the way down. That's a neutral human in the brachial chain. So then we do the same thing to the other side. Then lordosis, lift the middle of the neck, axial rotation in both directions, and then mid-cervical lateral flexion. So it's 1, 2, 3, and 4 tests. I just want us to knock those out and let you just feel them. Yes, ma'am.
So I'm a big communication person,
Uh-huh.
right? So obviously these are not tests that are usual for dentists to be providing.
Correct.
And nothing that we would normally be doing in our office. So how would we first communicate to the patient that we are looking at these things and that these are tests that we're, how do we
That's
say
an Alice question.
so that we prepare the patients, because they're going to go, what the frick are you doing? And, you know, I mean, because I'm sorry, but it is true. I mean, I've seen, you know, so many different seminars and my chiropractors and whatever, and they do the muscle testing, and other people call it quackery. And I'm
Exactly.
like, it's not quackery. You guys just don't even understand it. But most people will. So how do you transition into, we're going to start implementing some of these tests, and they're going, I've never had a dentist touch me below here. What do you do?
Take it.
Well, most of my patients that come in know that we take the total body approach to either restoring the mouth or figuring out their T&D problems. And so we always ask permission. And I go in and I would say, Rachel, today I'm going to do, after our interview, I have some clinical impressions of you because you kind of checked off the list as to my most likely. So unfortunately, you're not that unique, which is a good thing, right? And so, I'm seeing some things, and I have some clinical impressions. I think you're mainly on your right hemisphere. You're probably flaring your rib cage, and you have very uneven breathing. So I try to speak things in very layman's terms. Now, these clinical impressions, I may be wrong, so I'd like to get some objective data. Is that okay with you? Okay. So some of the things I'm going to do is I'm going to test the rotation of your neck, because my guess is some of the TMD issues you're having, some of the torque that you're having in your T is caused by muscle splinting or resistance of your muscles, or your muscles overworking in order to hold your breathing and your rib cage in a certain way. So I'm going to do some tests to see what your range of motion would be, and that will give me at least some objective data to work with. And so when we commence treatment, we can actually go back to objective data and say, qualitatively, how are you feeling? And quantitatively, what are we seeing? Okay, so patients appreciate quantitative data.
Now, absolutely perfect, and I see absolutely how that would happen. In my practice, I do not treat TMJ. And if anybody shows any kind of symptoms, I will not treat them until I send them over to see.
Hi, I'm
a
Amanda Canto.
Right?
I'm cosmetic dentist of Houston. It's really, really important to me that when I set your bite and I create a beautiful smile for you, it really matters to me that I make these veneers last and they look good and they don't change on you, they don't break on you. And my belief is that your entire body is associated with your smile. Everything's connected. We all hear about that. So would it be okay with you if I go outside the mouth a little bit and just evaluate your whole body, because I really want the dentistry to last for you. And if there are any problems that may come
That
up,
sounded good.
at least we know ahead of time and we can prevent that, so that the $50,000 that you spend in my office would be worthwhile. Would that be okay with you?
Yes.
How's that?
Perfect.
I'd do
So I
that.
bet
That'd be
you
cool.
no cosmetic dentist
They'd probably be impressed with that.
have ever
nobody
asked her
has.
that
Yeah.
question.
No.
So this is on her second opinion. Who do you think she's going to go to?
Absolutely.
Right.
Okay.
Yeah.
Perfect. Thank you.
So you take
That was
what's
good.
important
I was
to
digging
her,
that.
and you know what's important to you, and you find a way to connect them.
Absolutely.
Yeah.
Perfect. Thank you.
Okay. Awesome.
I was thinking of something that you were saying, and I was like wanting to jump in, and then I didn't, and
Okay,
now I've
so-
lost it. When I think of it, I'll say it.
So why don't we maybe move this way? We'll take half the
Wait.
team. James is going to take one team.
Yeah, grab that in.
Mike will take the other, and we're going to show y'all
There
how
we go.
to
Put a
do
little
the
space in
HDR
between 'em.
testing, which is so powerful, because if you're doing
Lied, I do have
Palatal
to put the
expander, if they're
I remembered.
orthodontic appliances,
I want to answer that what you were talking about that the weirdo quackery thing.
show them the value of what's going on. And at the same time, it helps you to get some objective data to see if you're heading in the right direction. Okay?
Remember when they were talking about applied kinesiology? Yeah, that's that whole, it drifts into the quackery land, because I've seen it all too, and I've been to these seminars, and I'm like, okay, give me a break. I cannot stand that. I crave objectivity. It's the whole reason 25 years ago I started getting into this science, because I realized it was very objective, but it wasn't a magic bullshit show. It was real live. We can look at things like internal rotation of that arm and feel a bony infield and know. We can look at femoral rotation on her, and she's probably going to have a limitation in external rotation on her right leg. That's what I would expect. In fact, if I don't see it, I'm going to go, that's
Check her
weird.
HGR,
And then I'll
we put her
start trying to
splint in,
sort
we
it
can
out
see
why I
the
didn't
difference. Well,
see it.
Tammy's got her splint.
But
So you can
what I have
try that yourself
at my
and see
disposal
it for
is
yourself.
I can implement the variable and remove the variable, re-implement the variable over and over again. And anytime you can do that, you're doing a scientific study right there with a subject of n equals 1. So in the case of Rachel with HGIR, I can implement a variable and see an improvement. I can remove the variable, Rachel take a breath, and I see that go away. And I know exactly why, because I know what those scapular positions are doing, and it lends credence to every single test. For me, and I dare say for y'all, if there is no credence or no explanation behind the test, it's just magic show slop bullcrap, and I don't want any part of it. And I value that objectivity, and I appreciate that question was good. I like that.
Can I add something to what Mike just said? You're going to be moving their arms and moving their neck. Make sure they know that it's not about their arm or their neck. It's about the restoration being successful, or the orthodontics case closing well, or the tongue tie work, or the
We're all
point work.
connected. I mean, we
It's
use
all
that
connected.
verbiage about the
But-
entire body's connected.
Yeah, but you let
Yeah,
them
so
know,
let's
we're
live it.
really gonna look specifically to find out that you on one side don't have something with your rib cage that could turn your neck into a position that would compromise your ability to be safe, secure, natural, and closed. So you can't let them know that, because they're like, why are you moving my arms? Why are you moving my neck? Your neck gives me a window into the relationship between your body and your jaw and your head, so that this all can go well long term. We need to screen that. It's that wellness thing that is so central to what you do. That's all you're doing. But just make sure when you're around the neck that you kind of let them know, hey, this is a bigger picture concept, and we learn about in your neck. This is a bigger picture concept in your rib cage that we learn about with your shoulder movement. But really, you're just finding out if the rib cage is collapsed, tip of the shoulder blade is pinching the arm. Because it's not a fake made up pinch, it's a real pinch. Once they get that, they're like, oh, okay, go ahead. Like, this sounds great, whatever.
So I would be curious, because I have been experiencing like this is almost like, feels like it's frozen, and I cannot get rid of this, like an impingement is what my chiropractor told me.
It is
And I'm
what it
like,
is.
why?
It is a-
And I wanna know why, and what do I do about it?
Bilateral type 1 scapulus.
Okay, so we gotta go, right now, what we're gonna do is we're gonna do an R&D, round robin. At Pink Institute, we do this thing called,
She's in
for those who have been, we call it CR round robin, right, Glenda? And CR round robin, we go around and, you know,
Yeah.
we bimanually guide everybody, we bimanually guide our instructors, and they'll give us feedback. So what we'll do first is we're gonna have the first half of the group in one table, second half in the other. And the instructors, Mike and James, will guide you to how to hold and how to position, okay? And we're gonna go really quickly through each of it. And then once you're done, Mike and James will get on the table, and then you guys come and swap, and they'll give you feedback as to how it feels and what your hands are doing and if you're hurting, okay? So let's split up the room and do half and half. We gotta get through this quickly if we're gonna get through our panel discussion.
And are we like using this human as the patient? Those are the two humans? Oh, okay, I got you.
If all you guys on this side just wanna come up here to my table.
And I'll take this half and come here. This is fun. This is cool. I'm digging this. You didn't know you were going to wind up on the table, did you? You're right here. You might as well be first up. You want to try it? Do you want to check the internal rotation first? Okay. You want me to do it first for you? And then, okay. So just take her, bring the arm out to the side, and just kind of get her to relax a little bit. Block her shoulder by just taking this portion that's open and just close it down. And you just try to keep this, because she has 90 look, but her shoulder's riding forward. So you just want to keep that from riding forward, and then bring your arm down until you run into that limitation, and there it is. So why don't you do this? Take your left hand and put it on that shoulder, and then take the right wrist, and just take her wrist down toward the table. And you feel the end right there. Bonk. It's like a brick wall. So now, why don't we just do it that way? You just everybody walk around that table. We'll just do a round robin of Tammy's poor shoulder. Yeah, so you want her at 90 degrees away from her body. And then you can take this thumb, and you don't even have to get in a pit. You can just kind of hang out right there. If she is, she'll find out, right? So you feel that little brick wall limitation, right? This is a kind of a fun way to do it. So we don't even need to be in the pit. You can just kind of park right here, and then take her down, and there's that limitation right there. This is like the funnest, easiest of all these tests. Almost. So let's kind of, and then what you want to do is so chill for a moment, and let's just take this hand, and then just hold it out. And then right there, you feel that end feel, how it's kind of hard? You've seen me do this a few times. I'll just park her right there. We do it enough, she's going to have a full range of motion shoulder. We're going to damage the damn thing. It's like, who cares? She'll live.
You won't fail for the.
Got it? Oh, heck yeah, you got it. That's as far as she goes. End range. While we're assessing, you guys can observe her. And what you notice is kind of what we saw in Rachel with Tammy. We're seeing this asymmetric rib cage presentation. Do you see it on her? Yeah, I mean, it's like right there. Okay, we've come full circle. Wow, you're back at the beginning again. So let's do the cervical lordosis, shall we? So on cervical lordosis, we're just taking your fingertips, placing them on each side of her neck, on the bones. So you know your spinous processes that stick straight out the back? Just fall right off of those into that little trough right next to them. And then she breathes in, she breathes out, and then you lift. And just feel what you feel. And this is one neck. I'll let you feel mine after you feel hers. I'm stiffer than she is. So you can feel her neck, which is moderate. Yeah, we're going to put her splint in a minute and let you feel it then. So once you've done that, I'll get on the table, let you feel mine. You'll go round, and then I'll jump down and you can feel mine and kind of know what a stiffer neck feels like. Because James says my neck's pretty stiff. Yeah, we're going to do it, one of us. Next. You go, Deanna. Get in there. I love it.
Create a fulcrum, and you'll bend over that fulcrum. So then you'll come over here and you'll create a west space fulcrum. You'll create the fulcrum, and then you'll take the head.
And just whatever you feel, don't worry about it. Just note what you felt and then do comparisons. Because this of the tests is the most subjective of all these tests I'm showing you.
Head's going into your fulcrum. There you go.
Go get him, Deanna. Got it? Got a little feel? Right?
I didn't know I was gonna be doing that.
With a different group, I mean, unfortunately, it's not the same.
So there's something I don't need to touch here.
I had no idea I was going to be using TAM for a test model. Just like, wait, what? Right? Yeah. Definitely, yeah. So she's got a very dominant right leg. She's living on that right leg. Give me a break. Get off that right leg. She's using her vastus lateralis as a femoral internal rotator. It's an squatting on the right side.
It's not a magic piece of wood. It's a wood that
And she's using that femur. It's another concept that it's like, let's go down a rabbit hole, but if her pelvis is oriented to the right, her femur orients right. But what she's doing is she's using tensor fasciae lata and vastus lateralis to internally rotate the femur straight ahead. Yeah. And many times it's hard to shut that off.
Okay, so here's what happened, just so nobody's confused. We put a piece of wood on the teeth so that his brain sensed this left side and his teeth guided his body. So literally turn his diaphragm this way.
Okay, so now comes cervical axial rotation. That looked great, looked great. And honestly, it wouldn't matter what it looked like. It's the easy test to do. Just lift as your pretest. Feel it. Then do whatever you're going to do treatment-wise. Feel it again. It'll probably feel different. That's what you're really looking for on that test, is the difference before and after. So if you were the worst tester on earth, who cares? Lousy test, implement, lousy test, but boy, she moves better. It's still just you. So there's no intra-rater reliability on this. It's all inter-rater reliability. So, oh wait, that is intra. Inter is between. All right, so cervical axial rotation is more difficult. This is a harder test to do. And you're going to feel awkward doing it. So I'm just giving you the heads up. And you got to do a ton of them before you get good at it. My left hand, remember, is not doing anything. It's the right hand rotating her to the left. Okay? So what I'm going to do is get as much of her vertebral column in my hand as possible. So I'm kind of clamping down on the entire vertebral column. Let me grab that neck so you can get X-ray vision.
That's okay. That's a neck that won't turn left. Inside then right.
So here's her neck in X-ray vision. I'm trying to clamp down on the entire column like that. Clamp to move it all as a unit. That's what I'm visually trying to accomplish.
Because the respiration
I'm going to set that on your belly, Tam.
the occlusion gave the respiration.
So,
See how the reciprocity goes both ways?
I kind of get as low as I can because her shoulders, this pedestal is her shoulders, they're stopping me. So I try to get as low as I can on the column. Who knew that thing was going to come in so handy? And then I'll clamp down on her neck, and then I'll rotate left. And that's as far as she goes without a splinter. So about 10 degrees maybe. There's 5, there's 10, she's at end. If I relax, I can cheat. There's 15, 25 maybe, there's 30. Get the idea? But I was literally doing nothing. If I clamp down, she's got about 10. I am clamping. Be firm.
Your brothers are outside.
Big hands, warm heart. Is that how that works? No. Yes.
You'll learn at 30 degrees. Once you get 30 degrees in your head, you kind of
Isn't that difficult? Yeah. So hop up for a second, Tammy. Lie down, Nan. Me. You. And we're going to do this on everybody. You're going to be up, down on this test. So now relax. I just want you to feel me doing this to you. She's got maybe 25 degrees. Feel the end?
Yeah.
Feel how I'm holding your neck?
Yeah.
Now hop up, Tammy back down. And we're just going to do this with everybody. Now go for it.
Again.
And we'll do it first. So what I'll do, tell me your name again.
Stephanie.
Damn it. Okay, Steph, so what's going to happen is we'll get Tammy to hop up. You'll lay down. I'll do your neck. Then hop back up. Then we'll do her neck.
Okay.
So you can kind of feel it and then do it. Not half bad. How's she feel?
Pretty good, yeah.
Decent?
I moved her up a little bit, yeah.
Good. Okay, that's great. Perfection. Nope, you're up. Stephanie's down. You'll be back down in a second.
Now
This,
you're making it work out.
this counts for sit-ups. Okay, so chill. And here we go. Chillax. I'll drive. Don't help. It's easy to want to help, huh? About 10 degrees right there. Bonk, bonk, bonk. Feel that? Bonk. Up. Tammy down. Have a neck. You're right. We're going to have to take her to dinner.
You were going to do that anyway.
Okay, dinner and a movie? Dinner and the zoo and NASA.
Is she too low?
She's being I don't know. What do you think? I mean, you're
Come up a little bit higher, I think, just a tad. Yeah, I know that doesn't seem like much, but I think it'll make a difference. Oh, yeah.
You feel that? That's the feeling. All right, Tam, you're up. See, y'all only have to lay down once. She's got to like 400 times, right? and it, tell me your name again.
Syra.
I knew that. Okay, and Syra's got a short neck, so I can only get like 2 or 3 fingers in there.
Yeah.
Don't be helping. She's got about 25 degrees. All right, you're up. Tammy's down. All right, so you felt what that felt like. See if you can match that. And Tammy will coach you a little bit. Shocking, positively shocking.
So hold it like a cup back here. This arm, yeah, this feels good. And then just rest the other one right here, like it felt. Yeah, and then just, yeah, you can just hold it there to relax. Yeah, I'll relax and you hold it. Getting a lot warmer.
Yeah, and I think the reason why is because you're carrying her into flexion as you're doing it. Did you notice? Yeah, she was kind of bringing her sort of like that.
A little tighter here. Did he hold you tight? Were you like really clamping down on
Hold her like I held you, okay?
Yeah, I mean,
Be firm. She's going to take it out on me anyway. You're okay. You're in the clear. All right, so you feel that bony end feel right there?
it doesn't hurt. Does it hurt? Yeah. It would if you kept pushing it. But no. It just
Got it? Deanna's down. All right. So you feel how I've got you? Here we go. So Deanna, you're right. There. 10 degrees. You're about like Tammy. This is the end. Your head goes further, but your neck stops there. Boom. Feel that? Okay, you're up. Tammy's down. Sorry.
I'm just in the way.
Now you're golden.
That head will feel like it goes further, but that's not what we're assessing. Because remember, those top 3 segments over-rotate. They're overly
Doing it right.
Do the best you can for a moment. Let Tammy coach you. Yes. Oh, I thought somebody called me.
I think you're turning it. I think it's more. I think you're doing more this than this.
I'm turning your neck.
Oh yeah, you're laterally flexing and there you go. That looks mo gooder.
Yeah.
I feel that. Okay.
That was bad English. Way mo gooder. Sorry. All right. Well, I'm getting my laps in too. I'm doing a lot of testing here. This is an easy neck. Not much motion, but it's an easy neck. So it's got about 5 degrees. Okay, you felt what I was doing, right? It's an easy neck. Doesn't move, but it's easy to grab. Not like Syra's neck. Syra's neck was short. Where's Syra? Oh, there you are. But it had more motion.
Move it up a little bit more. Right.
Like right,
About right there.
right there? Okay.
So you won't do anything. This hand does nothing other than just rest my head. So just pick my head up like it's a bowling ball.
Oh, okay.
Just pick up my head.
Okay, gotcha. And then
No,
Oh,
pick
pick
it
it up
up.
a little
Pick
bit
it
more?
up.
Okay.
I'm gonna rest my head in your hand
Okay,
and pick this
gotcha.
up. Pick my head up off the
even
table.
more? Okay.
Right there. Yeah.
Alright, and then I turn. Okay, yeah, I feel it tighten right.
Feel the end?
Mhm.
She getting you pretty decent, Tam?
Okay.
Yeah.
Cool.
The trick is to just make sure you're not pushing anybody into flexion or laterally flexing them while you're rotating them.
Right, okay.
We've been down this road. Hi.
Yes, we
I know this neck.
A week ago.
God, I done it. That's weird. You know how many times I've been to Houston this month? 3 times. 2 weeks ago, wait, 3 weeks ago, 2 weeks ago, last week in Boston. Yeah, except one, and I was in Boston that week.
Yeah.
Dang, dude. I need a life. All right, relax. 10. Boom. That's the end. You can feel that.
Yeah.
That. Okay, got it?
Yep.
Tammy, you're down.
See if Sophia tried to call your phone. She just tried to call mine, make sure she's okay.
Okay.
And there's the one way you just bring the slinky up.
Anytime my daughter calls, we better check.
This hand moved up just a little bit.
as you're going.
Yeah. Yep.
Did I get this right?
Is it more flexion? Look and see.
Let me watch from. Okay, so you're starting to laterally bend her, so make sure you're spinning her.
Gotcha, I gotta move this.
So
Yeah,
I'm
maybe
just
that's the
gonna
right word.
yeah, so
Spin it.
So keep this hand still. I think you're moving this hand too. Keep this hand and just like let the head rest on that hand.
Kind of like that.
That's really as far as you're gonna go.
Yeah, that's it.
Yeah,
You can
I
feel
don't
that
move
end.
a
When you
lot.
feel it, you know.
Doesn't go any further.
Oh, sorry, I left my phone there.
Trying real hard and I'm like, nope, that's not going.
I already did.
You did? Okay.
I already know mine 'cause he. No, I'm in braces, so.
Look at her apologizing for her neck findings. Now listen, I'm in braces and it's been a bad day. Shush.
Always a bad day for me.
Cracking me up. Was she on a roll today, like with all that? She was like going on earlier this morning. It's like, dang, Brenda. All right, chill. This is a neck like yours. Not much neck there. She's got not as much motion as you, though. We'll call it 10.
I can feel that all the way down my tailbone.
Isn't that wild?
Is that anatomical or is that muscle tension that's creating?
Anatomical. It's just there may be some muscle tension, but it's most. She just got a short neck. Some of God's children got a short neck. Some of God's children got a long neck. Isn't this an awkward test? Like I feel like all thumbs when I'm first learning to do this thing. I was like,
If I lost 20 pounds, I have more neck.
That's like a bowling ball. My head's literally gonna be heavy and your head's going through it. Perfect.
feel it? That's the end you're looking for. It's just bonk. Maestro. Did you already do it?
No.
Oh yeah, you're down.
I don't know who's done what.
I like to help.
Oh yeah, that's right. I remember this neck. All right, chillax, Karen. Don't help. All right, you're helping. I'm gonna sneak up on you.
You're just like, I'm done.
That's the end. So if I really keep your head in line with your neck, that's it, 10 degrees. That's about like Tammy's. All right, Tammy, you're down. Well, we got to do mid-cervical lateral flexion. So I saved the easiest test for last after this one. So lateral flexion is like anybody can do it. My favorite test, super easy. You don't have to be skilled.
Just pick up my head. Yep. And then do it like that. Yep.
Feel the end?
Yep.
Okay, it's fairly hard. Okay, mid-cervical lateral flexion is a breeze. So all you're doing with that, the right hand, if I'm bending her to the left, my right hand's doing the work. My left hand is just the hinge. So I place it somewhere in the middle of her neck and bend her around it. Just like that, bonk, bonk, that's the end. Not a lot of motion here.
So you want me to up, down?
Let's stay down. I think this one's fairly easy, and you can coach them fairly well on this one. So, right hand under the head,
Yeah.
left hand web space in the neck.
Wait, left hand what?
Just like put this part of her neck in this part of her hand. There you go, and then bend her around it. You feel how that just doesn't go? That's the end.
Yeah.
Now you might have been a little heavy with your thumb or something like that, but that's okay. You're not going to do it but a second, so you're not going to hurt anybody doing it. Tammy, I'm telling you, I appreciate you volunteering. She's like, volunteer? I was voluntold.
Right?
I don't know. You seemed a little timid to me when you were doing that assessment, right?
You need to have your hand up under here. Okay. Have your hand up under my skull.
Just like that.
other way.
There you go, Steph.
Okay.
And then web space of the hand, so let's do that. So you're just using this piece of your hand. You don't even need to touch her with this part. Just come right there. And bend her around the web space.
Yeah. Oh, okay.
Make
Like
sense?
a reverse choke.
Oh, okay.
I mean, you know.
Yeah, kind of is. Kind of is, yeah. Not that I choke her.
Yeah.
Yeah, they both improved, didn't they?
That it?
Yeah, your hands are warm.
Yeah, Rhys has to leave that in there.
That's great feedback. Right? Who cares about your technique, but your hands are warm.
I'm like, you're good. That's because I'm like, you just stay here. Yeah, pick the head up with the right hand first. Yep, you got it. The easy one.
I love this test. It's a breeze.
Just goes under my skull, like your whole, yep, yep, yep. Something doesn't feel right. Let's see. Maybe you just need to be a little tighter.
Tighter?
Maybe.
Oh, okay. Like that?
How's it look, Mike?
Looks good.
Okay.
There you
Yeah,
go.
I
You
think
got
the
it.
first time it was just so loose. It's like moving, working her, so she's gonna be.
I know.
Perfect.
Nailed it, baby.
Perfect.
Like an old vet, man. She walks in and just goes, boom, drops the mic and walks away. She's like, what? It's like in her wheelhouse. She's like, come on.
So you're turning it. Yeah, doing like a lateral flexion.
I got you.
I see one twice a week.
You get delivered on long enough, you can deliver. Okay.
Easier if you pick the head up first.
It is. Unload the head a little bit and then womp, womp, womp. So,
The reason it was easier is because I'm a lefty.
oh, that worked out well. You were like, boom.
The other one's harder for me.
Awkward. So what I want you to understand first, so Tammy has multiple complications in her world. In that case, there's an ALF and there's a splint. She's also a PRI vision patient. So she's in the middle of a postural vision program that we haven't even started. She's got her eyewear, but we have barely even begun that program. So we'll get mileage from her splint and or her ALF. I think in this case, we'll have you put both in, and then we'll take a look. The reason I'm telling you that is I want you to also take into account her rib flare. So what we're going to do is we'll conduct a bit of an experiment here, and this will be kind of fun. Nerd alert, right? She's married a nerd. She's going to write a book. I married a nerd. Do what?
Oh my God, yes.
Right?
Baby, I've got my appliance.
Foreplay.
I see you lacing up your sneakers. Hang on, we're so. All right, let's just. Yes, ma'am. Give us just a moment. Just give us just a moment. So let's at least look at this. So can a couple of you come and just test? And I just want you to appreciate that improvement. So she can gain nearly 90.
I didn't get her down all the way. Did I not do it right?
No, you're fine. You can take her down.
Yes, but before, she was just going this far.
Yes.
She needs some
So
PRI.
I know it. So take her down. Yeah, there you go. And then hold her there and just take her and take her. Just take her all the way down because she'll go. I just took her myself. So that's what I want you to, and don't be bashful. When you bring her out here into 90 degrees of abduction, don't be bashful. I mean, this is not bothering her at all. Yeah, she's like literally below. I've got a Buick parked on this shoulder. I know what you felt before, and that brick that you felt when the splint was not in her mouth. It's like when you bring her here, you're almost afraid that you're going to feel that brick, and so you I begin to feel an end range here. That is not the end. There's the end right there. So I just want you to not be timid on that. Because these are your patients. They're going to walk in doing this. Patients seem to enjoy this test of all these tests the most because they can see it.
That's the one that I always hear the patients go, oh my God.
Right? You're up, Deanna.
I have a table that
Let's take that hand, park it here. You don't want that pit. There you go. Keep her down and just take her on down.
Push harder. Push into the table.
It stops a lot sooner that way.
Yeah, push hard, doesn't matter. It'll keep pushing the arm down.
It's going. It's gone, man.
There's no pain. Yeah, there's no pain. Okay. Before there was pain.
When you start to run into resistance, I want you to tell me, and we're going to have some fun.
Yeah, a little bit.
So you feel like you're starting to run into some resistance? Now bring her back up, take a breath, and breathe out.
Now I go?
Take her down.
Oh yeah, much easier.
Isn't that crazy, right?
Yeah.
So I want you to appreciate that also happens at the neck in all planes of movement. All the splint and the ALF are doing is giving us the freedom to even begin.
So hang on 1 second. On the shoulder? Yeah, right in there.
Yeah, because that's non-Cairo, right? It's like, wait a minute, what? You can take her further. I promise you she'll go.
Yeah, but I don't want to hurt her.
It's like
I love you guys. You're such dentists. You know? It's like the PTs will be like, button up. Let me hurt this lady. You know, they can't wait to hurt her. Go for it.
Because I can just tell that it stops. Yeah. I mean, I know that it's not painful, but I can just tell that it stops. I'm like, okay, that's where she stops. That's like me with the shoes, you know, where I stop, but it's not 90, but it's close.
Significantly improved, right? So one thing I want you to appreciate, let's assume that your patient has a rotator cuff impingement. So this actually is a test called a Hawkins-Kennedy test. And a Hawkins-Kennedy test done upright, you would hold the patient like, you would do something like this. That's a Hawkins-Kennedy test to evoke an impingement, so it irritates the tendon.
Don't mess me up more than
No, I'm not gonna mess you up. So when you're doing this test, before without her splint, we get pain about at 40 degrees. So what I want you to appreciate is we can take her to 40 degrees, there's a hard end feel, and there's pain because we're impinging the rotator cuff with the lesser tubercle of the humeral head. But now she can go almost to 90 with very little. This would be her true end range, but there's no impingement. If we take that rib cage in, while she has that in, we have 90 plus with no limitation in end range. Yeah, we just did it a minute ago. All right, so so the mission is put a permission slip in the mouth, teach the patient how to marry the permission slip. So that marriage becomes the abdominal program, the left adductor program, inhibit the right adductor, find a right glute max, find a left neck, find left peripheral vision, she's got it. That's the mission. Now we're done on this robin.
So we gotta go that way.
So we're switching now?
So for Gabe, I need to show you my before braces and my after braces.
Mike,
Okay.
we don't have time to switch. I think we need to do our.
Oh, we've had a good robin here.
I think we've had a good Robin. Yeah.
All right, let's panel.
Do you want a panel or do you want to show what she can do?
Oh yeah, no, it's time for this case. We have a case before panel.
Look, so this is my bite before.
Mm-hmm.
Okay, so if you guys could all sit down.
And you can see that I have a cross bite here.
Real interesting case to show you guys.
They were literally sticking when I would smile. You would see one stick up in the back. So it's like I had a baby tooth. And
Oh,
my
isn't that
pictures.
wild?
So I started to fake my smile and I stopped smiling. So that's before ortho, that's 2013. And then this is.
Mm-hmm.
So immediately.
Yeah, this
The
is
eyes
happening.
got
Yeah.
better. That's what. So when I come see you officially and I get a splint and I learn how to breathe better and get into
You'll
my
feel
left side of my body, will my eyes not?
I
look-
want
will-
to see that change.
That's what they want to see.
That's what I'm looking for.
Okay.
Do you want me to sit in
I'm
here or
so
you want me to
excited.
stand?
Marilyn?
Yes.
Marilyn hasn't tried it yet.
Oh, yeah, Marilyn. Oh, you didn't get a chance to get a hand on a neck?
No.
You poor neglected soul. Hey, Tammy, can I borrow your neck real quick? She's been a good model.
She's the fabulous model.
Right.
You have a whole weekend.
Right.
Did you bring your doghouse with you?
Comes on wheels. I packed it in my carry-on. It's inflatable. Which test did you not get to do?
None of them.
Oh, you were totally neglected, James.
Yes.
All right, so humeral glenoid internal. Are you splinted right now?
Yeah.
That's okay.
Yeah.
So she's got a splint in her mouth right now, so she's going to have increased rotation. All you're doing is parking a truck on the shoulder and rotating the arm down until you start to feel an end range. And I'm getting it right about almost at the table.
Okay.
So why don't you give it a try? So take her by the wrist, swing her out into 90 degrees of abduction.
Like this.
So right about there.
Oh, well, that's up high.
And then park a Buick on the shoulder.
All right. Okay, there we go.
And then rotate while that's holding that firmly. Take her arm down toward the table until you start to feel that limitation. It's going to be close to the table, right there. Now, if she didn't have her appliance in her mouth, the end range is going to be right about here.
Yeah, I put it in a few minutes ago.
Yeah, because we had everybody test with it or without it and then with it. Let's check the neck. So the way the neck rotation is, the first one is just lifting the middle of the neck, like that.
All right.
So go ahead, that's the easiest one, so go ahead and do that. Well, second easiest.
So right in the middle.
Mm-hmm. And then lift a little bit.
Okay.
Now that lift is actually improved from what she normally has.
Is that it?
And then you let it go and do it a couple of times. Just lift a little bit and just feel what it feels like.
I'm trying to build.
Uh-huh. Just like that.
Okay.
And you know, sometimes I'll take a neck
Mm-hmm.
and I'll, where's the spinous process? Right there. So
On
let's
this
go on
side?
each side.
Okay.
And then I'll relax and I just lift. Let it go
Okay.
and lift again.
Mm-hmm.
And just feel what that feels like. Like that.
Okay. Okay.
Cervical axial rotation's a little bit more difficult. Hop up, Tammy.
Differently.
Yeah.
How so?
So before, like, I kind of had, I don't know how to explain, but like, you kind of had to collect the food and then try to like push it through. But now it's more so like, I can move my tongue like all around like that now. So I'm able to like literally sweep the food and then just kind of just like keep the tongue and then just move it back.
Are you thinking about when you're doing it, or is the tongue just naturally?
It's kind of like forcing me to do it that way because now it just feels right. I don't know how to, you know what I mean?
Yeah, it just
feels
right.
Yeah.
Oh.
And so like before, I used to ask Deanne all the time, like, are you, like, where exactly do I have to put the tip of my tongue? But now it's like, I know exactly where it is because it just feels right.
It's almost like now you go, how could I not have known this?
Right, yeah, it's like, now it's kind of like, the main thing I kept thinking was like, I shouldn't have worried. I don't know, like, where I should keep my tongue.
You shouldn't. It should be natural.
Right. You know, when we're trying to tell people about that, who are in that boat, as you know,
right.
It's just a foreign concept. They do not get what we're saying. Yeah.
That's pretty cool.
Okay.
I mean, I'm sure about I'm still a question on that. Okay.
Yeah. So I saw Deanna right after. I don't know, to be honest, right now because it's too early.
I just want to make sure.
Yeah. So that's it, yeah.
Otherwise
So,
we can leave it out. So,
yeah.
Oh, it's on the slide.
Yeah.
Okay, so I think that's a good ending. Does anyone have any burning questions?
When is the next one in Houston?
It's a good question.
Do you guys want more of this?
Yeah, I want to have Christy's information card calling an appointment.
Yeah, I need some more referral forms.
We talked about that.
I don't.
Can we just go Do you want me to make?
Because that would be great, because I also, I had to go for, I mean,
I've got a lot on my list now.
I love the fact that we're already involved in
And then
the
the
front
partial
end of the
restoration, which
And I mean, I
past
saw
couple
from
of days,
of course,
well,
the
yesterday
Facebook,
when they mentioned
and
that
mine
person
are
had a
the
breastfeeding
same.
option, and then it was
I'm like trying to make sure I can just tour
one
it.
thing of like,
Yes.
if you're really trying to do something out.
I sent you an email.
I don't know enough information, I haven't done a complete, bite evaluation. This one was more evaluation.
Chrissy, speak louder.
I have a patient that was in Invisalign that, she was fun all the time, she's a brand new patient, we just saw her, I mean, we just saw her.
Everybody?
Wanted to live.
But anyway,
December 20th or something, her left joint made a loud pop, and she has trigeminal neuralgia, and her tongue is numb. The orthodontist, I don't know who the orthodontist is, she says, I only have 2 trays left, should I finish? It's like, no, we're good right now.
She's in ortho?
She's in Invisalign. So do you think, I don't know what the loud pop was, I checked that day because I was just doing a kind of a hygiene check. Range of motion, the jaw is fine. I just got a panel, I don't have the CT scans yet. She brought me an MRI, I haven't even looked at it yet. Haven't looked at her bite too much yet. But range of motion of the jaw is fine. She's tracking fine. I mean, I don't see any limited jaw movements. I don't see anything that would cause a disease.
I can tell you right now,
Do
one
you
of the
think that-
pitfalls of Invisalign, you really got to know your posture before you offer someone Invisalign. Because if a patient is clenching to lift that rib cage so they can so that they can balance themselves and move, you know they're going to clench in their Invisalign. And when they do that, they're going to distalize that condyle and pop that in and cause an anterior.
But do you think that could cause neuralgia?
Yeah.
I mean, that's pretty severe.
Yeah, because, okay, so there's this thing called trigeminal cardiac reflex. Y'all heard about that? Trigeminal cardiac reflex. So, you can look that up. It's a whole topic. I don't want to get into it, but.
No, we'll talk about it later.
Yeah, there's.
What's the neuralgia she's feeling or he's feeling? What is it?
Numbing.
Lower left lip and the whole left side of the tongue.
I had another patient who had a tongue numb, and we couldn't ever resolve it. We couldn't resolve it.
Are you absolutely sure there's not?
If you're doing cardiac variability.
I haven't done
like heart variability.
When I do a TMD workup, it's an hour and a half. And I haven't done all of that.
But you scrolled through the CBCT and there's no infection.
No, I don't have a CBCT yet. She brought me, she said she already had one, but it was actually an MRI. I haven't looked at it yet.
Because like seriously, 3 years ago.
Well, I'll tell you what, guys, let's, why don't we go ahead and wrap it up now? And we'll just call it a day. Thanks a lot.
Thank
We'll
you.
here.